Good afternoon, everybody, and welcome to our NHS West Yorkshire Integrated Care Board meeting today. This is our third full meeting in public, together as an Integrated Care Board, which is part of our West Yorkshire Health and Care Partnership. For those watching on our live stream, I'm Cathy Elliott. I am the Chair of NHS West Yorkshire ICB and Deputy Chair of our Integrated Partnership. There are so many people around the table today who are members of our board, as well as colleagues who've come particularly to talk to us today about our focus on topic on workforce. And I just ask you, colleagues, as you make your first contribution or comment or ask a question, please introduce yourself and explain your role on the board or your contribution today. We're coming together, as always, to fulfil the four purposes of an integrated care system around improving healthcare and outcomes for our local people in West Yorkshire, around tackling inequalities and variation in care, enhancing the productivity and value for money, and also supporting the broader and economic and social development in our communities. And I hope what you can see, whether you're sat around this table or you're watching online or have read the documents, that you can see that that's what we're striving to achieve. For members of the public and for members of staff as well, all the documents for today's meeting are available online, and they are available per item as well, so hopefully that makes it accessible to you. As always, as we've done for the last two meetings and for our third full meeting in public today here in Leeds, we have a focus on topic which is on workforce. And we will be spending well over an hour today looking at the breadth and depth of our health and care workforce. And thank you to Kate Sims, our Director of People, and many colleagues who've worked with her in preparing for that session today. We also, just for the record, but also to share, we've had an engagement session earlier today as a board members to talk to people who are working in healthcare across the whole of West Yorkshire in different places and in different sectors, to hear their experiences, to hear about the barriers they're facing, the concerns they have, but also the great work that is taking place and the opportunities we have as a partnership. And I really thank them for their contributions today, which have been noted. I hope they can see they'll come into the discussions today, and also the action that we take as a result of that. So I suppose that is all on our introductions today. We will also be looking at our winter resilience planning as usual, and hearing from colleagues around places and within our core team on our continued delivery of that. In terms of apologies, we have a number. Laura, do you want to just do those for me? Thank you.
Thank you. We've got apologies today from Julian Hartley and Brendan Brown is deputising, from Robin Tuddenham and Neil Smurthwaite is deputising, and also from Councillor Swift. I believe those are the ones we have for this afternoon.
We then move on to the minutes of the last meeting that we had in public on the 15th of November in Huddersfield. Colleagues, do you feel that's a true reflection of our meeting that day? Yeah. Becky.
Just to say that I think we still haven't quite got the children and young people reporting right. So we had the feedback session in September. We've talked about the nature how we're going to get feedback, but Rob very specifically asked each place for a report at that meeting. I don't think that's clear enough in the minutes. And then as a sort of matter of arising, if we look through the minutes, we've got page 46, page 51, page 59, lots and lots of recognition about issues around children and young people. It's not consolidated. So just in terms of matters arising from the minutes, Cathy, that I think I don't think I'm clear still as a board member about the action to bring down waiting times and how places are reporting, and if we've got any difference to young people and their families' ability to access support as a result of the work we've been doing since September.
Okay, thank you very much. So in matters arising, I had a similar point as well in looking into that. So I think if we can take the action for places to come back. Rob, what are your thoughts?
Can't see if that's on or not. Oh, it's on. Okay, thank you. I don't know if Tim wants to say anything from a children's programme perspective. Clearly, we've got to monitor our responsiveness for access to services for children through the Finance Performance Committee, and have to ensure that that's happening. And then there are the pieces of work we're doing to prioritise our work around what's the offer in each place tailored to the different populations in each place. That's something that's been considered in places, and the children's programme's been consolidating its work. So it would be useful, I think, if there's anything from Finance Performance Committee perspective, or if any of the places want to contribute, or if Tim wants to comment from a children's programme perspective.
Great. Thank you. Tim, do you want to share your thoughts? And I think then we just take this as still an outstanding action from places. Tim?
Yeah, I'm happy to. I think it goes back to some of the discussions we've had about the role of programme boards. Clearly, the sort of key performance pieces, as Rob has said, have report through that Finance and Performance Committee, and I think that's where that should sit and should continue to sit. And that includes a look at place level information and data, as well as the broader West Yorkshire piece. And then the programme board, in terms of the Children's Programme Board, we look at the work programme that we've set out and those indicators and performance in the areas that we've prioritised as a partnership in that space. I'm nervous that we then create a sort of third route round those two. I'm not convinced that's what we ought to be doing. I think those two together are the primary routes through to the board on all the information, whether it's about children's or about anything else.
Okay. So I think, Becky, do you want to respond?
Is that it? Yeah. I understand all of that, but we have, for instance, waiting times for various procedures in the NHS, and we have something around waiting times for neurodisabilities that's a percentage, not a numbers again. So we aren't actually reporting it in terms of our dashboard in the same way, I don't think. I don't feel we are.
Okay. I think if we can take that outside of the meeting then to look at the reporting, look at the representation in the dashboard, and also look at what we can hear from the programme board as a follow-up.
Sure, I think when we get to the dashboard, if there are, I know that the team have got the absolute numbers as well as the percentages, we can talk them through, Becky, if that's helpful.
Yeah. Okay, thank you, Becky. I'm just going to go back round again and say I'm checking that the minutes of the last meeting are a fair reflection. Everyone's happy with that. We've got one matter arising that we've just talked through. Are there any other matters arising? Otherwise, we'll get straight onto the action log. No? Okay, so the action log we have from our last meeting. So if you remember when we were in Huddersfield in November, we had a focus on primary care. So that's why we have a number of actions around primary care. And I know colleagues are ready to share updates from with us, which would be really welcome. But Laura, are there any other actions you want to provide an update on?
Thank you. If I could just run down those that are flagged as open, if that's okay, just so we can close those and provide people with an update. So the first open action is number 9. I don't know if Hannah would like to give an update on that. I know that a meeting's scheduled to talk about the ongoing feedback from from individuals who kindly participate in our engagement sessions.
Yeah, I suppose it's linked to the point that Becky just mentioned there around the insight and feedback from people living in West Yorkshire and how we use that and how that work is, and then how that's used and then how we feed that back to people about what we're doing. So I think it's something that we want to, over this next session, if we can bring something back to the next board meeting, that would be good.
Thank you. I'll carry on down the action log. So the next two open actions, 17 and 18, Bev's just going to give a brief update on. Thank you.
Thank you. So in terms of the, sorry, I'm just scrolling down. In terms of action, minute 25, focus on children and young people. So that plan has been developed via the Children's Programme Board. Partners around the table, including everyone from place, and we've got priority areas, and as Tim's just alluded to, we monitor that through each programme board, so I think that's now closed. And in terms of minute 26, work in relation to the CQC, it says recent, that was, I think it was last May, we brought that back at a previous board, is my recollection, so I also believe that's closed. Thank you.
Thank you. Sorry, I've just been informed that our live streaming isn't working, so we will try and resolve that, but we'll carry on as we are. Okay. Thank you, Karen. Apologies for being distracted. Our next open action is action 20, and Jonathan's to give a brief update on that one. Thank you.
Thank you. So, following the discussion at the last board meeting, I fed back some of the conversation that we had to the West Yorkshire Capital and Estate Strategy Board. primary care estates is clearly on that board's agenda, and we're doing some further work across all places to do a stock take on how PCN estates needs fit into the overall piece. So I think we can probably close that action now.
Thank you. And our next open action is number 27, and I'll pass to Anthony, please.
Yeah, thank you. So this was to feed back to the Mental Health, Learning Disability and Autism Collaborative, the question around whether we could introduce more standardisation, looking at the sort of variation we have between waiting times in the statutory sector and other sectors. So we did play that back to colleagues in the collaborative. They provided a note in terms of the work they're doing around a deep dive into neurodiversity, which has been going on throughout 2022-23, and some of the work that's emerging from that deep dive is around how they improve consistency, how we can support, how we can ensure the right support is available for people who are waiting for assessment, and also about implementing the right to choose. So that particularly that point about improving consistency is a core part of the programme. So I'll share that note for completeness to circulate after the meeting, but that was the feedback from the programme.
And I believe the next open action is for yourself, Cafe.
Oh, 29, yes. So this is something that we've put onto the board assurance framework around looking at local authority financial situation in relation to system working and the NHS. So I think we can call it closed in terms of putting it on the board assurance framework and noticing it as a system risk. And also we have begun board discussions on financial planning for the new financial year. So I'd really welcome local authority colleagues around the table and part of our board as well, an overall partnership to work with us. And I know we've got a partnership meeting coming up at the beginning of September, so I think that's going to be a good opportunity then.
And the final open action is number 32, and I'll pass back to Anthony. Thank you.
Yes, thanks. This was around the EPRR policy that we looked at in the last meeting, and the question was around whether learning from the independent review on the impact of inequalities had been taken into account in this work. It hasn't been, I think, is the point to confirm explicitly. So we've agreed to pick that up as part of the ongoing development of the policy, and we'll include that in the report back in March.
Okay. That's all of the open actions, unless there were any queries on any that we're proposing for closure.
Okay. Great, thank you very much. And colleagues, it sometimes seems a strange way to start the meeting, but we need to make sure we finished off where we left off to then start today. So thank you for sharing those updates. I also wanted to check in on the primary care session that we had last time. As you know, we had an engagement session with local people using general practice services, and then we also had a group of GPs who came and met with us, and we had a full paper and a discussion on barriers faced and opportunities. So Ian, would you just give us an update on the Fuller Delivery Board, which was what the board supported last time, and the place leads around the table as well? If there are any updates from you, particularly on the infrastructure support for primary care, we'd really welcome hearing about that. Ian.
Yeah, thanks, Cathy. So the Fuller Delivery Board met in December, I think, Carol. It was chaired by Carol McKenna, which was great. I guess the starting point for that conversation was the discussion that we'd had here in November and the work that we'll work on collectively as an ICB, as well as the engagement session that we'd had in the morning, where we heard from users of primary and community services. I think there was the direction and what we proposed was really supported by members from Place. I think there's a real need to focus on where we add value at West Yorkshire level, and that's on enablers like estates, workforce, capital, as well as some of the infrastructure models that we had a conversation about last time. So first meeting in December, I think we've got the next meeting next month, but it felt like it was a positive start.
Great, thank you very much. And place leads around the table, a welcomed update. Tim, then Carol, would you introduce yourself so everyone knows which places you're from? That'd be really helpful.
Yeah, hello, Tim Riley, place lead for Leeds. I suppose I think reflecting on the infrastructure piece, it's important we don't forget that probably a lot of us have been working on this for a while, although there's still more to do. So I just thought it'd be useful to let colleagues know a few of the things. I do believe it's really important we don't forget, because it sometimes gets lost out of sight. that the ICB teams in places and as a system provide the digital support, so that infrastructure is there. I think we've strengthened that in Leeds and we'll continue to strengthen it by the work with Leeds City Council and creating an integrated team, because that adds additional resilience. But I sometimes think we forget that, and I don't think we should. There are a couple of other areas, certainly in Leeds, one of the things we've been doing for a number of years now is providing additional support. So each PCN gets about £20,000 a year to play its part in the Leeds system. They've brought that together and use it once through a GP confederation. That gives some infrastructure as well, which I think then can be built on, so they start to win contracts, which then can be built on, and so on. So we're beginning to see that bear fruit, and that then enables that confederation of all the GP practices to start to think about how it might do some of that broader infrastructure work. So it's a sort of pump priming of that to get that engagement and then build that infrastructure. The GP Confederation in Leeds, working with LCH, have got shared posts in terms of medical director, nursing director, and the support into primary care nursing. And also LCH provide a sort of employ-deploy model for some of the R's roles to some of the PCNs, which I think, again, gives some additional resilience there. I suppose the three bits where I think we still need to do some more work. One is around business intelligence support. We're getting to a place where I think that is right on the cusp of being where we want it to be, and providing that particularly into PCNs and the local care partnerships. The second area is around estates, and I really would welcome that West Yorkshire view. I think Ian's absolutely right. That's something we need to look at a West Yorkshire level in many ways, but we also need to look at it as a place, because there's something about one place strategies around estates and starting to think how different partners within a place can use their buildings more effectively. And again, that's conversations Tom and I and others have had. And then the third area is how we use the ICB team capacity within Leeds. And we're very clear that that reports into a sort of triumvirate of LCH, the GP Confed leadership, and myself. And a lot of that resource is then directed by that group of three sitting beneath the programme board. And I do believe that we're moving away from purely a contractual model. There are contractual elements, but a number of those teams actually work with and alongside practices. And I think that's an area we're continuing to explore and develop.
Great, thank you very much. I think it's really helpful to hear that board time spent has moved into action and further thinking, or it's reassured good work that's been taking place for months or years or so. So we'll go to Jo next, and then if we could come to Mel and then Neil. Jo, would you introduce yourself?
Yeah, so I'm Jo Webster, I'm the place lead for Wakefield Place. I think it's fair to say that since Wakefield had the opportunity for Vanguard, our development of our GP Federation and confederations has really emerged, and I think as a result of that over the years that's been able to mature, probably in advance of maybe some of the other places, on reflection, just listening to the conversation. So what we have in Wakefield is is called Connexus. Part of that is GP Care Wakefield, and that offers a range of support to our PCN networks, and that ranges from HR support in relation to some of the challenges that they face, financial support in terms of some of the financial challenges, and the planning that they need to do. It does all the comms and engagement for our general practice. It's got a commercial side to it, which they are beginning to get more momentum around bulk purchasing and sort of trying to look at opportunities so it becomes more efficient. It offers training on a much larger scale than individual practices having to purchase that. And it also does the at-scale delivery for the things that are better to be placed across the whole Wakefield. So it does all our health checks, it does the research element of it, it does our urgent care contract, our same-day access, and provides that infrastructure. And I suppose in times where general practice is facing the pressure of demand alongside any other providers, it also offers a resilience to all our general practices, both on a network level and then on an individual level. So there's still lots more to do on estate, there's still lots more to do on business intelligence and digital, but I think we've probably, we've got a really strong foundation in Wakefield of which to build on, and I think we get a lot of benefit of that in the conversations that we have amongst the other providers in the district in terms of having that single voice for GP and primary care in Wakefield.
Great, thank you, Jo. Mel, over to you.
Thank you very much, Chair. I'm Mel Pickup, place-based lead for Bradford District in Craven and Chief Executive of Bradford Teaching Hospitals. So we do not have that single infrastructure organisation in Bradford. We have 3 federations, but we have an overarching body that has been shaped by calling together all the clinical directors of the PCNs and has a GP as its chair. And following the meeting last time, we have met as a place, myself as the place lead, our GP who is our primary care lead for the Health and Care Partnership, other colleagues as well as the chair and the chief operating officer of Bradford Care Alliance, and discuss with them some of their challenges, which are not unique to Bradford, very, very similar to all the other areas that you have already heard about and will hear about, I'm sure. Workforce, how we approach the appointment of ours roles, our estate, the strength and resilience of our digital infrastructure, and indeed the role of the Care Alliance and the challenge that is there something more formal that we could bring to bear within the Bradford place that would give us an opportunity to strengthen that primary care voice. And we have established a number of meetings that will explore that excuse me, further with a wider audience of GP colleagues, as well as extending an invitation to Rob and James to do a session similar to that that has been held in Kirklees, which was very welcomed by our chair of Bradford Care Alliance.
A bit of a mix of all those sort of descriptions, really. We don't have a single infrastructure that enables to do some of that stuff at scale. What we do have, though, is good GP participation in our partnership board. So we have 2 GP members as well as the LMC on our partnership board. We also have a GP leadership forum, which includes our clinical directors, the LMC, our old CCG, GP leadership as well, that sort of come together. We have invested over the years to try and get that more federated model to get economies of scale, but it's slow and it's difficult to achieve. But we do achieve in other areas. So we've got a great model for our Rs. I think we're one of the only places where we maximise our Rs spend every year and utilise the full budget, and that's with a range of partners. So we have CHFT, SWIFT and the council all employing those in a sort of an equal model. We've also sort of recognised the benefits of population health management. So we've had the NAPC working with our clinical directors and our PCNs the last 3 years on that data side of things. And we think with the new roles coming in with regards to ours, there's an ability to sort of not provide additional investment because we don't have that money, but use that investment wisely for those roles around digital and BI to provide that BI infrastructure. Because as with Leeds, we're recognising using data in a different way to help change that model is vital to primary care sustainability.
Thank you very much, colleagues, for sharing the update. There's a temptation now to get back into that discussion on primary care, but that was the focus for our last meeting. I really appreciate the updates from all the places. We have said that an update from the Fuller Delivery Board would come in a few months' time, so probably the July board, I'd suggest, but please come back and say the appropriate timing. This is incredibly important, and I think our live stream is working fully now, so for anyone, particularly members of the public watching our meeting, there is a continued oversight, insight and progress on quality improvement and developments and transformation in primary care, because we know it's incredibly important to our health and care system as well as to our residents as well. Okay, thank you very much for those updates. That's the action log done. And something, as you know, we're learning, and this is only our third full meeting in public, is how we run the format to these meetings. And I'm really pleased to see so much action and discussion and developments coming out of the last focus on session. And we're about to get into the next one. And we'll make sure that we have time in the meeting to hear about the developments. The next item on the agenda is item 9, which are public questions. We don't have any public questions today. We do note that people continually to contact us across our health and care partnership, across places and services and organisations. And there are many different ways in which members of the public can ask questions and gain feedback. We continually welcome that. We are grateful to our colleagues at Healthwatch that continually share with us insights, as well as run engagement sessions for our board as well. So I think it's just a reminder to say you can submit a question to the board in relation to that meeting's agenda around 24 hours before the meeting, and our next meeting will be in March. But also all the organisations represented around this table offer the opportunity to provide feedback and also ask public questions. And also if it's of an area of concern, including complaints, we have a robust complaints process now in place for the Integrated Care Board. So I'll leave that there. So we're going to move on now to our Focus On session. And we've chosen workforce. It is an enormous topic for us. But it is our biggest investment and the most important part of delivering health and care in many ways. And I'm grateful, again, I'm going to say this, Kate, because you put so much preparation into this, to you and colleagues for preparing this Focus On session. Perhaps people watching and perhaps other people working in boards might think taking over an hour to focus on something is quite a luxury, but we feel this is incredibly important. And we know by spending the time with the talent and the expertise and the representation around this board, we can have some really productive discussions to make change and improvement and support our colleagues across the breadth of health and care. So, Kate, it's over to you for the next hour or so.
Thank you very much, and hello everyone. I'm Kate Sims. I'm the Director of People for the ICB. Anybody knows giving me an hour is a dangerous thing. I can feel that. Just like to start with the context of thanking our colleagues who came this morning. We had an informal engagement session with the board from colleagues across the workforce of health and care, and I know board members have found that really informative. This was about that personal experience of working across our system, and I know we took some really good pieces away from that. Thank you first for this opportunity, all of you, but thank you mostly for the people at the other end of the table who are going to join me in this presentation. Cathy, you've opened it up really well there by saying this is a vast topic, and the first thing is I won't propose to take everybody through the paper or what was a 70, I think, slide data set, and that is a vast amount of information. Today's purpose is very much a presentation which reflects on core aspects of both of those, so we'll assume it's well read from that point of view. And I've been given the task of also being in charge of the clicker. So there we go, it's working. Thank you very much. Just a couple of comments from myself, thank you, before I hand over to all of my colleagues. And I will introduce you as we go round. This is the first Focus On workforce session, and I felt it was therefore really important that the first thing we did is to provide a West Yorkshire workforce picture, hence the data slides. We'll come on to data, I'm sure, later on, but there is something about making sure that all of us on the board have got as much of a flavour as we can in terms of the facts and figures around our current workforce from that point of view. The next thing is to start to describe our responses to those challenges, both at the West Yorkshire system level, and again, we've chosen some areas of that today. We couldn't possibly take you through all of that. But as importantly, it's that joint collaboration with our colleagues. So you will know that I have chosen 2 places in both Wakefield and Bradford, colleagues, really grateful to you, and one sector which is social care. And again, I think really important for all of us from that point of view. When we get into the people plan, you will feel also that we've primarily focused on growing for the future and new ways of working out of that plan which is available. And I think that's because we recognise that the number across our workforce and retaining our people, but also finding different ways of working, are absolutely critical. So I will apologise now that when it comes to some of the other aspects of our people plan, it's not that we don't take that seriously, it's just, again, we will come back to another session and choose different places, different sectors and different parts of the people plan. It would be fair to say some of our people plans in place and at sector level are still in development. Of course they are, and we're continually looking at those, and from my perspective, making sure that we link the West Yorkshire plan from that point of view. So in summary, I think just from summary conclusions from me, hopefully from the report that you've read. Firstly, of course, our workforce is absolutely critical to our success, both in terms of delivery of our service, but also in our transformation from that point of view. I think there are some big challenges. I think the first of those challenges are the current numbers of people that we have available to develop and deliver our services. And I think also our ability to attract people, and that will come out today in some of the conversations that we have. Our ability to retain people is critical, and there are some workforce demographic challenges of that. We have lots of people who are due to retire. We have labour market challenges. We recognise that we are in a very competitive labour market at the moment. And also we need to ask ourselves around our working environment, is it a great place for people to work? I think a key thing for us as all is that we recognise we must look after our people in these pressured times. And I think it came up this morning, we must in this busy time also enable our people to still develop and to thrive so that they wish to retain their place within health and care in West Yorkshire. Data availability and accuracy is a challenge, and I will say that now, and even some of the slides we'll take you through in a moment will recognise we have the data that we have at the moment, but we are ambitious in terms of how we can really take that forward. So the first part of today's presentation, I will hand over to Jonathan Brown, who's the Associate Director of Workforce Strategy and Planning within my own team in the People Directorate. I'm delighted also to introduce Gaynor Clark, who works as our Workforce Planning Lead, Health Education England team, who are embedded within the West Yorkshire Partnership. The purpose of the first section is to present you with a bit of a quick brief look through the current state of play effectively across our workforce. The second bit then is to respond in terms we were asked to look specifically about workforce planning across the system. There will be a pause at that stage. We'll pause the presentation at that stage and hopefully have about a 20-minute opportunity for discussion before we then invite our colleagues from place. So I will hand over to Jonathan and Gaynor and go off on mute. Thank you.
Thanks for the introduction, Kate, and thank you for being here today and having this opportunity to speak with you all. I want to start by saying it's a really exciting month for us in workforce planning. January through till March is at the time where we are really engaging with the whole system to try and pull together what we hope will eventually be an integrated plan for West Yorkshire workforce. And we're getting there in stages, and I'm going to just explain to you how that might work. So the first slide shows us perhaps where we've been. The left-hand 1, 2, 3, 4, 5 lines, the y-axis is actually the number of people employed in West Yorkshire in the NHS organisations, including the community interest companies. And you can see each line is a year. So 2018 is the line at the bottom. I'm sorry it's not very clear on the slide deck, so I'll have to try and just walk through it. 2018 is the year at the bottom. And at the end of that year, we had about 52,800 people working in the NHS and the community interest companies. And if you go to the very top, the green line is 2022. And at the end of August, we were at 61,000. So there has been year-on-year growth in NHS and community interest company workforce. A lot of that growth actually has been in medicine, but there has been growth. On the right-hand side, is basically what's happening within this year. And so you'll see each one of those bars is a month, starting with March 22. And the green line at the very top is the operating plan that we submitted to NHS England, suggesting where we wanted to be with our workforce numbers during this calendar year. And it was ambitious. What it said was that we would reduce our spend on bank and agency and locum people, and we would increase our operating workforce people in post by somewhere around about 3%. As the year's gone by, that ambition hasn't been entirely realised, but we've made solid progress. And where we've not necessarily met the ambition of the staff in post, we have made that up in terms of bank agency and locum. And I think that's a really interesting scenario when there's pressure on cost of living and so on. How does that impact people if we actually did achieve the plan and they weren't able to gain those extra working hours and the extra income, of course, that comes with it. So the story really is we have grown over the past 5 years in overall numbers of substantive people in post. And during this year, we have more workforce as the year's gone on, but we've perhaps not quite met the ambition that we really wanted in secondary and the NHS sector. Thanks, Kate. Oh, brilliant. The yellow line, again, I'm sorry, there's probably the details in your pack, I'm sure you, but the yellow line is the progress against the plan we have in primary care for GP numbers. And it starts at the very left-hand end in March 2019. It ends at this end in October 22. And you will see through 21 and 22 a slight reduction in GP numbers. And then you'll see a big kick up there, sort of round about July, August 22. And that's because of the increased numbers of GPs coming through in training. So what you're seeing there is the impact of more trainee doctors in primary care, in general practice. The bar charts again show progress over this year against what the plan said. The orange bit, in fact, is overall GPs, excluding training grades, and you can see that's a fairly static number. The blue is nurses, again a fairly static number, but I think there's something to celebrate in the red and green boxes, which are the ARS roles that we've spoken about previously, where we're getting more appointments in primary care through those new and changing roles. You know, examples, nursing associates, paramedics, physios and so on, working in direct contact with patients at the front. I'm going to hand over to Gaynor now.
So, of course, one of the priorities of the ICB is to create a more integrated workforce plan, to bring more information into our plans for future workforce from the different sectors. This is just illustrating some of the data, this information that's available for adult social care. This is skills for care data, and it's produced on an annual basis. This shows us across West Yorkshire 57,000 people working in, posts in adult social care, which is nearly as many as the NHS posts that we've got, full-time equivalent. So it's a substantial part of our workforce. It's also showing, obviously, that we've reduced the number of filled posts since the previous reporting year and increased the number of vacancies. I'm not going to go into much detail on this data because Richard and Louise are going to talk in greater detail about adult social care later on, and I don't want to steal their thunder. But just to show the kind of data that is available both for different staff groups and at local authority levels, so we can talk to Place about those. This next data set is a really new data set that we're bringing. It's not a new data set, but it's new to bringing into our overall position, looking at just trying to estimate the size of the voluntary sector, volunteers, people employed in the voluntary sector. And it shows a huge number of people, 121,000 estimated volunteers across West Yorkshire Combined Authority, which is, again, double the number of people working in adult social care and NHS. I don't profess to know a lot of detail about this data set. This is an emerging data set that we're bringing into our considerations across West Yorkshire, but we've made some good links with people at Place who have a lot of information about this workforce. So that's something we're going to build on over the next few months and years.
So, forgive me. The next slide is about growth aspiration. We, in order to get to an integrated plan, we've spoken to the leadership teams in places. It's important for us to get their input on the way in which the future workforce should be developed. Why we need to know that centrally is that there's an enormous amount of investment made into West Yorkshire by the NHS England, by Health Education England in the hundreds of millions, and that investment underpins the workforce changes that we might want to make, and is one of the single biggest levers, I guess, for introducing new roles, for developing our existing workforce, and for the supply of new people. So we've been out to places, and we've been out to all the organisations within Place to collect in their ambition for workforce for the next 5 years, and we've driven that through places so that what we're trying to say is that if you've got a strategic plan that says you're going to deliver services differently locally, then we need to understand what those workforce changes would like in order for you to actually achieve that plan. Workforce planning is a bit of a dark art, isn't it? And we've traditionally taken the numbers we've got and we've said, well, we'll do 2% more on that particular line of staff and so on and so forth. But we're really trying to get into this idea that workforce planning is about service delivery first. So what does the workforce need to look like to support that service delivery? Hence this quite mighty process really that's got us to this point. And you'll see here some really big aspiration in allied health professionals and in the qualified healthcare scientist groups. I think it's risky to try and analyse why that is, but one big suspicion we have is that they're really good at engaging in this. I just want to quickly whiz on to some of the things that we're doing to improve what we have and what we'll have in the future. And these are our sort of 5 big priority areas that we've agreed within the team and with places in order to get us towards that integrated workforce plan. And it's going to take us a bit of time. The multi-year modelling I've just mentioned, the idea of that multi-year modelling is to have the best possible way and evidence-based to influence that spending of the big money on education and training. We have asked people in the national bodies of HE and NHS England to say that we really need to put much better workforce information in the hands of leadership at place level. At the moment, we're being told that that isn't available. And so we've asked for a national data pilot. We don't own all this data. It's quite hard to manipulate it and gather it without putting burden on the system. So whatever's in the national systems, we want them to be able to deliver that to us in a way that's really helpful for places. So that's a national pilot that we're working on. The system tells us it would be really helpful to have a workforce planning cycle that aligns with business planning, that aligns with the way that services are developing, and we're going to put that in place. That probably includes us understanding better how we think about finance, workforce and activity lining up as well. We have a transformation plan which has come from places and from organisations, and it tells us where people believe we should be investing in new roles and transformation, and using some of that in-year money that is in the system for developing the workforce in that way. A really exciting development for us is that of the Workforce Observatory, which again is striving to give us a different approach to workforce planning, a longer term view, so that we're getting into that population focused way of planning the workforce, and also to be able to do deep dives into area where we think we need some real focus. Within the joint forward plan, it says 2 things. The easy one is it says we should have an integrated workforce plan. That's the easy one. The other thing it says that we really as an ICB should be paying attention to the education and training of the workforce. Now, I just want to tell you a bit about what it looks like at the moment. The investment in future workforce at the moment, in terms of placements, this is like a bucket, and you'll see the sort of light blue colour, the big bit, that's secondary care. That's where our placements are currently for newly qualified people. And we know that you tend to want to work where you trained. So this is one of those change ethoses that says, if we continue to do this, we're going to get more of the same. If we continue to do this, we're going to get more of the same. So we'll get more growth, more people in secondary care, when actually the Joint Forward Plan says we want to tackle inequalities and we want to shift from repair to retention, to prevention, then we probably need to think about what we do in community to actually really tackle that. And if I've got a personal view on this, I think it's that we focus entirely on the learning environment in community so that it's just as important and seen as just as a great place to work as it is in the acute. Otherwise, we're not going to shift the way those new professionals see the world for the future, and we won't get a change. That's a personal view, obviously, but it is something that we've actually heard repeatedly through place dialogue in those multi-year modelling events. I won't dwell on this one, But even if we want to continue with the model we've got now, there's serious challenges in terms of growing the workforce because of this placement restriction. There's a tipping point beyond which you say you can't really go much further. You know, placements tend to make the workforce less productive, or there's some evidence that they make the workforce less productive. And there's a safety limit to how many trainees you can have in a working environment compared to the number of professionals to support and train them when they're there. So this placement thing for me is a system-wide thing for us to really engage in. Thanks, Kate. I won't dwell. I think I'm probably going over time. Yeah, the other way to boost the workforce, and the fastest way to boost the workforce numbers, is through international recruitment, because it circumnavigates some of that placement. It circumnavigates the 4-year delay in getting a new nurse, or the 12-year delay in getting a new doctor. So we have a plan around system-wide international recruitment. But what we really don't want to do is to repeat history in this area. We want to be great global citizens, and we want pathways of recruitment that are ethical, sustainable, financially viable. And the journey of those professionals is the first and foremost consideration. So we're working again in partnership with Health Education England to develop those pathways, working with local places and the clinical leaders in those places to get the right roles and the right relationships. And indeed, we've managed to negotiate a relationship with the state of Kerala, which is a government-to-government arrangement, which will help them move some of their unemployed nurses into the UK in a really, truly ethical way. Thanks, Kate. We will be thinking about workforce planning in terms of this education and training investment as we move forward. It is a lever for change, and one that we really need to dig into. We have had the opportunity to influence the way Health Education England is spending their money. We've had senior leaders from the ICB sitting on panels to help us, with sorting through bids that have come in through places and through organisations, so that we're doing the right things for the system in that regard. And obviously the massive relationship here with the HEIs is critical. You know, the NHS is one big learning environment, really. The amount of people that are in training at any given time and the learning that happens every day at the clinical front end is so critical, and our universities obviously underpin that, and we're going to build those relationships and really help with that. And of course, the placement investment made by HE has to mirror the newly qualified staff in the universities, and we've got to get that right, and we've got to get it in the right places, and the HEIs can really help us to do that. I'm done. Sorry, I've run over.
Thanks, Jonathan. So I was just waiting for you to turn that. Thank you very much. I mean, the first part of this presentation, there's a huge amount more detail that you'll have all seen in the paper and in the slide deck, was really just to set some of the scene, to indicate that, we know that there are workforce numbers challenges. The workforce is growing, but I'm sure it doesn't always feel like that at times for colleagues. I think the other aspect is the working closely with all of our partners right across place, and I think I'm certainly starting to see those place-based multi-year discussions really happening now. I think the message that we've heard back from places is very much the one that Jonathan's touched on there about placements and making sure that actually we've got sufficient placements out in the rest of our sectors, not just in secondary care. And there is a lot of detail in the paper which summarises this slide here around workforce transformation and lots of examples of where we are trying new roles out, paramedics out in PCN areas, students, and in social care in terms of placements, all sorts of examples there. So Cathy, as chair, we thought we'd pause there to see if there's any sort of aspects of this part of the presentation that anybody wanted to pick up before we move into the rest of the people plan, and also our place-based colleagues.
Okay, Jonathan and Gaynor, thank you for that part of the presentation. Kate, particularly, how can the board help you today? What kind of questions do you have for us today as a group of leaders across our health and care partnership?
I guess there's a range of things. I mean, obviously the recommendations, the first one is really firstly to note, I guess, the current state of play across the workforce. And I absolutely recognise there is a huge amount more detail that we could provide in some parts of our sectors than others. So I guess it's firstly to note and acknowledge that. And I think, you know, you'll hear from the place-based people plans in a moment. These are still in development. And I think there's something about what we recognise as some of the priorities. I do think there will be some asks of the board. Jonathan's touched on briefly there around our workforce observatory. For those who aren't familiar with that, we have had an excellent relationship with Bradford University so far. And there is a business case that we are developing because we recognise that workforce planning at the complexity that we're looking at is a really significant piece, but it needs to be evidence-based and it does need to have some academic rigour. So there will be some asks, I'm sure, Cathy, around, you know, from the board, you know, around those sorts of developments that are coming through. I think for today, it's noting, I guess, the complexity of this challenge. And I think we've already touched on the priority word earlier on today. What are the key priorities? We will list some of those that we believe as this presentation goes on, but happy to have that conversation with colleagues.
Okay, thank you, Kate. So we've got about 15-20 minutes now, and then we're going to go on to the next part of the presentation. So I think we've got Richard, Tom, AC, and then Fatima, and then Becky. So Richard, will you start us off, and then Majid? Okay.
Thank you. Yes, thank you for that. I'm Richard Vautry, the primary care member of the board. Not surprisingly, I'm interested in that GP slide that you showed, which is really quite alarming, and it reflects the national picture of general practice, where we know that there is positive news around the number of GP trainees coming into the system, but really negative views that actually you saw those slides, that line declining each year because we're not retaining the GPs that we've got. And I just wonder what we could do to look at the retention sort of side of the equation. You've, in the pack, shown slides around NHS staff surveys. That doesn't apply to general practice. Is there a way that we can start surveying our general practice colleagues and general practice teams on a regular basis to actually get their views, and also maybe do some exit interviews, sort of when GPs or others, practice nurses, leave the profession? Can we just maybe firstly thank them for the service that they've given, because often they don't get any recognition from the system as a whole when they leave, but also ask them what their views were, what their reasons for leaving were, and whether we can learn from that as a system. And then my second point is around the primary care network staff that are coming in to our service. Really welcome. And as Neil mentioned, in some areas they're able to spend all the budget. In other areas that's not the case. And in part that's also because of the challenges of everybody trying to recruit at the same time. But also it's an issue of retention. You know, and how do we avoid sort of, you know, people just moving around the system from one job to another and end up not spending a resource that we've got? We really need to find a way of maximising that resource as much as possible. And then the final point was about placements. I really do think we do need to encourage more medical school placements, nursing placements. Many of our practice nurses are at the older end of their careers, and we need younger nurses to train in general practice settings and community-based settings so they get that experience from the off, so that they then feel actually that's a place that they can work in for their future career.
Great. Kate, how would you like to take these questions? Because I've got another 8 people. So
May I suggest that we hear a few and then try and bring a few responses together, because I suspect there may be some themes, if that's okay.
Yeah, of course. And we're noting this all down. So some really practical suggestions there. Thank you, Richard, as always. And also some things for the team to take forward. So next we've got Tom, and then AC, and then Fatima. Tom, would you introduce yourself, Tom?
Sure, is that on? Yeah? Yeah, Tom Reardon, I'm Chief Executive of Leeds City Council. I think this is a really important piece of work. I just encourage the team to not try and do everything, and to really, almost for the board, to give you permission to prioritise. That there are some areas to me that will be almost impossible to join up everything, but others where it really will make sense for us to work across West Yorkshire as a whole. One would be international recruitment, which is obviously one of your priorities. I thought there was good coverage of social care, and we've got public health obviously as well in councils and the VCS sector in the sort of assessment bit, but then not as it followed through into actions. So on international recruitment, we're already struggling for social workers at the moment. We're trying to work together on some of that, and that could make a real difference. There's really good practice in the NHS about how you help people with the housing when they land in the city. And, you know, I think there's things that we could join up on and learn more on there. We could link it to our, you know, house building programmes in each place as well, for example. I think there's also possibly issues around workforce in all our organisations in terms of some of the impact of COVID and the long-term effects of health conditions on people with caring responsibilities or them themselves, and the sickness issues that are going to be continuing. So is there something around that we could be doing more together, mental health support, for example? And then I was really pleased that you mentioned community and the sort of micro, because I do think there are big opportunities for us to almost go organisation blind into communities as a collective and try and recruit, which would obviously help our EDI agenda quite considerably as well if we got that right. Thank you.
Great. Thanks, Tom. AC, would you introduce yourself?
Thanks, Kathy. I'm Nanshu Chatterjee, Non-Executive Director. I think Tom has kindly covered two of the observations that I was going to make, but just to sort of build on that, firstly, thanks, Kate and team, for this sort of comprehensive piece of work. But as I've said before as well and shared with yourself and team, it would be useful to sort of pick out key focus area and prioritize that, because it's a massive amount of work. So that would be useful to see, and how it specifically links with our investment plans, which you have touched upon, as well as looking at sort of transformation plans, because they sort of dovetail each other. Second point was looking at the international recruitment. Of course, placement and building workforce is a long-term sort of activity. However, it would be useful to give the board an indication what support you would need for, are there any sort of challenges around international recruitment, and also look at the data trends over the last 3 years on how much of each sector international recruitment has shifted, specifically from EU and non-EU countries. Because that would be, I think, useful then to cite for both for Kathy and Robin upward discussions.
Okay, thank you very much. That was really wide-ranging on primary care, retention, placements, international recruitment, more on action plans for social care, voluntary sector, public health, and then really having an eye on the benefits and our learning so far on international recruitment. If you want to take those, and then we'll hear from the next three people.
Thank you. No, that's some really helpful points there, and I've probably not got them in the right order, but I think, Tom, your point there about priorities, and I think one of the constant tasks for us is to make sure where can we have the most impact at system level, and I think international recruitment is one that definitely there is a huge appetite. It's fairly well established within the NHS, so the issue for us now is, rather than create another industry, is how can we make sure that our NHS colleagues are able to share that expertise. And certainly we're already working closely with colleagues in social care who've approached us to say, can you come and help us from a system-wide point of view? And I understand that, you know, that the point around actually some of the deep dive, and I think as we get into further future workforce sessions with the board, Kathy, we can get into some real detail on a particular topic if that suits. Absolutely agree with the surveying, Richard. You know, your point that it's not yet available, and there's something about how do we make that happen with yourselves. Something around staff surveying. You talked about exit interviews. For me, there's something also about retention interviews. What makes people stay is often more critical than knowing why people have left. I think there's a thank you, as you said, but there is something about really working through with some of that. And certainly my links through the primary care discussion last time was very much around how can we help with some of that through the workforce steering group from that perspective. But I think there is this constant piece, and hopefully you'll get that sense at the second half of the presentation, which are the bits that we would focus on across the system, and which are the bits that actually both places and indeed sectors are actually already doing really well for themselves. They may need some of our input, but not necessarily right across the board. Thanks,
okay,
Kathy.
Thank you. We've next got Fatima, Becky, and then Majid. Fatima.
Good afternoon, everyone. My name is Fatima Khan-Shah. I'm proud to be an Associate Director here in the Health and Care Partnership and to convene our Race Equality Network. I suppose my sort of reflections, Kate, are a bit of an insight to rebellion, which is unsurprising because it's me that's saying it, which is when it comes to the workforce planning, are we fully harnessing the potential of this health and care partnership in the way in which we're designing the way we work. So COVID flipped everything on its head, and people had to get out of their comfort zones and work in very radical new models of care. And since COVID, we've kind of gone back to, not all, but very similar ways to how we've done it before. And I just wondered whether actually there's an opportunity for us when we're doing the longer term game of being much more radical in the skill set and abilities that we're trying to cultivate in our workforce. So they are much more all-rounders and can move around the system, which would address some of the issues that we've seen before. I suppose my other reflection is about, quite rightly, as Tom's pointed out, our commitment to really trying to target and attract people from our grassroots communities, because people will be invested if they have an emotional commitment or link to this organisation. I work here because I love this partnership. I'm committed to its people. And I suppose, are there practical things we can do with our workforce to really cultivate that feeling of commitment and belonging? And when you're thinking about the international recruitment, where they live and how they settle in is really important. Have we given that thought? Are we really thinking through that transition? Because it can be quite traumatic, as some of the network members have told me. And then I suppose the final one is, what is our aspiration for the workforce of the future? So I was watching this panorama interview last night, and there were people that were coming in and out of people's homes, doing testing in the property, blood tests, scans, etc. And it blew my mind, and I just thought, well, actually, there is a real opportunity for us to not only utilise the people that are working, employed within our partnership, but the people that are in our houses that are looking after those people. Have we considered them as part of our workforce? Do we know the numbers, and are we investing in them? And I just suppose I'm very committed to what you're doing, but I think we could be much more ambitious.
Okay, thank you, Fatima. Becky, then Majid.
Becky Malby, non-executive member. I was looking at the nursing, midwifery and health visiting, and obviously those are quite different professions, and I know you lump everything together, but we've looking through the board papers, we've had on our eyes on the risk around midwifery for some time now, and particularly around some of the models of care for midwifery that reward people, and that the shortage of midwives has meant that we aren't able to offer the same types of rewarding experience, being able to offer continuity of care, etc. So I guess looking at your SIP, that it looked absolutely astronomical jump in terms of what's apparently planned and what we apparently need, from 3 to 13%. That feels huge. So given the state of midwifery, I think it'd be really helpful to understand where midwifery is and what's realistic about midwifery, and then what might we need to do together across the system around midwifery to offer something that's rewarding and beneficial for us as West Yorkshire.
Thank you, Becky. I had that as well in terms of our higher vacancy rates that we have in midwifery, health visiting and allied health professionals. But we'll just take a comment from Majid, and then Kate, maybe you want to respond, and then we've got 3 more people. Do you want to respond on that point, Ian? Okay. We'll come over to Majid. Would you introduce yourself?
Hi, everybody. I'm Majid Hussain, one of the non-exec members. So, few points. I'll be quick, though. The first one, this morning, we met some amazing colleagues from across the health and care sector. They spoke about all the challenges that exist within the system, but they also had some brilliant ideas about what we could do to make things better. So in terms of co-production with our staff, how are we making sure that they are involved in the answers? And when I'm looking at the staff survey, the lowest score, which is 5.4, it says we are always learning, which scores poorly and stuff. So just want to connect them 2 points and say, what are we doing to sort of make sure that we are listening and responding and stuff. Second point was we have huge challenges around diversity and stuff, and I know we've got a huge commitment in that area. Are we going far enough, and how far are we prepared to go? So you look at other sectors, you got positive action people in the heart of communities, encouraging people to take up some of these careers, supporting with all aspects of recruitment and stuff. Next thing was linked to that point is really pleased to see the inclusive recruitment toolkit. Now, within the equality space, we've seen equality schemes, equality objectives, you name it, we've seen the lot. But have they all made a difference? No. So that what we need to know here is, how are we going to make sure that this toolkit is embedded, is working, and is going to make a difference?
Thank you, Majid. Do you want to respond on that, Kate? And then we'll take the next round of comments. So then we've got Bev, Harris, Rachel, Ian and Kim, and then we will move to the next part of the presentation.
Thank you. I mean, there's many comments on, and I know we could have a really full day on this,
yeah.
And I think that's the risk.
Yes.
and also the opportunity. So I suppose there's a couple of things. I think, Fatima, your point around that sort of really making sure that we're being ambitious enough. And I'm conscious that both Gaynor and Jonathan, you've led some of these place-based professional discussions and opportunities around longer term sort of workforce planning. So I might just ask you, I'm also really mindful, I've got colleagues here from our places who are going to talk about their people plans in a moment. So some of the issues that have been raised here today around attracting people right across our communities. I'm looking at Philip, and you're going to talk about, even some of the ambition around the academy approach in Wakefield. So I'm mindful, if I may, not to sort of get into that and then have that sort of repeated from that point of view. I think Becky's challenge around the different size of the professions and the different size of the challenge, this is where the workforce group then has to work closely with the different either sector groups or professional groups. So I'm looking at people like Bev and colleagues around the midwifery workforce. It's working with colleagues to say, what is our solutions over the next 5 years, both in terms of both attraction and retention, but also different roles that may be able to be developed as part of that. And I don't know if Bev's looking to come in on that very point.
Bev, do you want to come in and... Yep.
Yeah. Beverly Geary, Director of Nursing, West Yorkshire ICB. So yeah, I will come in on that point if I may. So in terms of midwifery, we've got a really robust workforce plan that is overseen by the LNMS, all provider organisations that deliver maternity services are part of that. We've introduced new roles, as you've just said, Kate, that include registered nurses in theatres, for example, so that midwives are with women. And in addition, there are big ambitions around the non-registered workforce and introduction of new roles. So we've got that plan. It's really robust and it's overseen at system level by the LNMS. And if I may, then I'm going to go on to some other points. So in terms of place, I've got a couple of points, so bear with me. So in terms of placements, I think there's a massive opportunity, particularly in primary care. Point that you made, Jonathan, around, I think it were about 85% of placements in secondary care. And you also said that it makes the workforce less productive. That's because mentorship is required from registered nurses. And it's a big ask, being a mentor, and some people, unfortunately, some of our registrants choose not to do it because it's in addition to, a really busy job already. So I think as West Yorkshire we could look at something different, for example, peripatetic mentorship. So whether we do that at organisational level or whether we do it at West Yorkshire level and work with our education providers, I think that's something that would be worth looking at. I think in terms of international recruitment, there's a risk coming. So we started on this road almost 3 years. Well, I know it were before for you, Jonathan, but in provider land about 3 years ago, and a lot of the contracts were for 3 years. And we know at that point that England wasn't the first choice. It was America. Now America is opening up, and there's more opportunity at the moment. Our cost of living crisis is impacting on everyone, and we know that our international registrants, they come in at band 5. So housing in Leeds, so your point, Tom, we need to look at things like, support for international registrants to keep them here, because actually, cost of housing in Leeds, for example, on a band 5 salary for a single individual, is that, does that stop people coming? I think in addition we need to look at the development for our internationally registered colleagues, because we know that in our region, and we are typical in West Yorkshire, many of our international registrants, there's a ceiling at band 6, which is junior sister for those of you that are not aware. So we need to look at that. I'm talking about nursing specifically, so apologies for that. So I think there's, at a West Yorkshire level, do we look at opportunities, career development opportunities for our international registered staff? And then my final point is about retention, because we heard this morning from these really inspirational people around we've got to be flexible, mindful that the vast majority of health and social care is 24/7, 365 days of the year. But the second, we do collect information. We do collect information about people that are leaving from the NHS, and it's collated via ESR. 5 of our organisations haven't fed that up to region, by the way. But the second reason for people leaving the NHS in the last 12 months was retirement. So these are really experienced staff. So there's something about flexibility for staff, not just retiring, all staff, I think, but, you know, flexible retirement options. And also there's something about pensions that I don't know enough about to comment on, but the conversations that I'm privy to and the people that I have conversations with are around options for people around pensions and flexibility. I'll leave it there. Thank you.
Thank you very much, Bev. That's incredibly helpful. I would like to just take the comments from the last group of people, and then we can move on to the presentation. This is what happened with this vast subject that we entered into. So we've got Harris, then Rachel, then Ian, then Kim. And then maybe, Kate, you want to reflect on that, and then we'll come to the next part of the presentation. But I think we're just about on time. Harris, over to you. Would you introduce yourself?
Hi, I'm Harris Sultan. I'm on the Next Director scheme, which is a non-executive development placement. Thank you, Kate, for a very comprehensive overview of the workforce. So I've got 2 points. My first one's on the future workforce, particularly students. And I know Chief Exec of NHS England, Amanda Pritchard, last week demanded more places for medical schools in the Times words. But I think we talk about staff morale and retention. The British Medical Association said 4 in 10 junior doctors have thought about leaving the NHS, with 2/3 researching an alternative career. As a med student myself, I know that what our experience on placement really represents whether we want to go into the profession in the future. So what are we doing about, as well as retaining the current staff, ensuring their morale's up and they have the ability to mentor the future workforce so they stay, so we're not hemorrhaging staff after med school, after university as well. My second point is on the future. So as Richard said, how are we aligning that students that come out of university align with our current ambition of having more of a primary care and community-based approach? But also on that note, we're very digital here and we're very digitally savvy. Have we got that aligned with university's ambitions of staffing the future of virtual wards are becoming more of the norm, and also online consultations? Is that translated into the training, or is there a barrier there? Thank you.
Thank you very much, Harris. That's incredibly helpful. So you're making notes, Kate, aren't you, as we go along? Thank you. To Rachel next, then Ian, then Kim.
Hi, I'm Rachel Spencer-Henschel. I'm the Director of Public Health for Kirklees, representing public health directors here at the ICB. Just a couple of points. I think it's such a huge area of work is this, and I know that you're never going to cover absolutely everything in a presentation like this. I would just say that I think the slide on equality and diversity, clearly that says by Agenda for Change band and protected characteristics, but obviously there's a hell of a lot more of protected characteristics than just the 2 listed. And I suppose it was just to gain a bit of assurance that we're looking at all of those protected characteristics, and also where that's it produces intersectionality, because we know in terms of retention particularly as well as recruitment, but it's how we address support around staff and their different needs and assets within those communities. So that was just a point about presentation, I guess. My other point is, I sometimes think as well, we've talked a lot about kind of the front line, and I'm very conscious that that's what's in the headlines, and that very much translates into patient care and patient experience. But I think it was Tim who said earlier about the real importance about good intelligence and data to inform what we're doing. And I guess there's an opportunity for me to say, well, we've all probably got some kind of intelligence and performance capacity that I suspect is mostly focused on measuring things and activity rather than actually saying, well, what do we need to be focusing on as a system? And I guess the benefit of the system, particularly the West Yorkshire one, is our ability to actually say, what can we do upstream to make a difference and make sure our precious resource is focused on the things that we need it to be focused on. So I guess it was just to get a sense around sort of some of the less frontline stuff that's nonetheless important. And I think it does link to Harris's point about the workforce for the future, and that kind of technologically savvy staff, and how we kind of grow and develop them with the new technologies coming on board. Thank you.
Great. Thank you, Rachel. So continuing theme on business intelligence, data, and the importance of quality placements there. So we've got Ian, then Kim.
Thanks, Cathy. Ian Holmes, Director of Strategy and Partnerships. I'll be super quick. I'd really welcome a conversation around dentistry. You know, I think we all understand the access issues and workforce pressures, and there's probably something we could do together around international recruitment, retention, skill mix. So I know everyone's saying, you know, narrow this down and prioritise, but I think that should be one of our priorities. Thanks.
Thank you, Ian. And Kim.
Hi, I'm Kim Shuttler. I'm here representing the voluntary and community sector. So we're in a no different position to other people. It was interesting that when we've been surveying sector leaders, retention came up as their number one worry that's keeping them up at night, which isn't surprising, but sort of is surprising because historically recruitment and retention in the sector hasn't been as that challenge. People come and work in the voluntary and community sector because they really, really love it and are committed to working probably in just a different environment of health and care and, you know, and choose that pathway. But suddenly you see people leaving because of the cost of living because, you know, that isn't enough, all that love isn't enough to pay the bills. The good news, I think, is in terms of the conversations that we're having in the partnership about some of the 7 recommendations that we've been working with the places around sector sustainability, and there's some key areas in that around looking at negotiations of the contracts, about looking at where possible to have that longer term funding, because it's heartbreaking, I think, to hear and experience myself as the Chief Executive of a charity, making people redundant who are excellent and contributing a huge amount to our system when we know that there are workforce pressures in other parts where they can't recruit. So I think there's more opportunity for us to explore how we sort of avoid kind of the robbing Peter to pay Paul, where people, you know, we're losing people from the sector to go to other places that are paying maybe 10, 15,000 more, but actually how do we plan around that so there might be some rotating opportunities, so people might come into organisations like my own with a lived experience pathway that looks different from coming into a clinical pathway, but actually there's a clear planned progression for them to move into a different part, perhaps the NHS or the care sector. So I think there's a great opportunity around that, and I think it's really heartening to see it in the presentation, so thank you, Kate.
Great. Okay, thank you for all those contributions. I know colleagues around the table who've made presentations are taking lots of notes. Stacey here is also making notes from the meeting. So I think if we move on to the next section on the presentation, Kate, and then maybe we could do some summing up at the end, and we're going to aim to finish by about 20 to 3-ish.
Thank you to everybody. I think there's been some really useful questions, challenge, and also proposals there. So I haven't lost any of those. I'm not ignoring them, but we will move on. I just wanted to start the next section, which is, so we've heard about some of the workforce planning and the integration around this. And the next stage is just to, I guess, finish off with the West Yorkshire People Plan firstly. And I'll apologise at the start to say I'm not going to loiter on these slides. I'm very, very happy, as I said at the beginning, that next time we focus on some of the other pillars. For those who aren't familiar, we have a pillar around belonging to the West Yorkshire Partnership. Of course, that starts with attraction, but it's particularly around some of the areas of retention, but also our EDI agenda, our equality, diversity and inclusion agenda. So there are aspects there of what we are working on from a system-wide point of view, but for the purpose of time for today, we won't spend much time on those. It's in the paper. Looking after our people, I think a huge part of retention is the value we put on people, but also making sure that they have access to help when they need it. And I think one of the things I'm already really proud of us as a partnership is how we've really started to grip the aspect of making that a system-wide offer. Recently, you'll all be familiar with the fact that the Mental Health and Wellbeing Hub here in West Yorkshire, we've had it confirmed through you all that we've had that approved as a permanent feature when it did have short-term funding. That is a piece that is accessible to all of our staff. So I've already had conversations with colleagues from VCSE, social care, primary care, about how we really make sure that they are people who access this as members of the workforce. Lots of other examples from that perspective.
And everything we've talked about is around system development and system leadership and how we work as a system. And there is some really great activity happening around that, but I won't pause on that for the purpose of today. So, without further ado, what I'd like to do is introduce, firstly, Dominic and Philip, and I know you'll both declare who you are in a moment, who would like to take you through, firstly, a sense of the Wakefield Partnership People Plan and some of the work that's being covered there. But secondly, Philip has a very specific initiative to share. So firstly, Dominic, Associate Director of System Workforce for the Wakefield Partnership, and Philip Marshall, some of you I'm sure will have met Philip, Director of Workforce and Organisational Development at the Mid-Yorkshire Hospitals, but also joint SRO with Dr. Linda Harris, who would have loved to have been here with us today, but obviously at Spectrum they have some appointment processes today. So thank you both. I'll drive your slides.
Thanks, Kate. And just to start by reflecting back on some of the comments that have been made, because we've been grappling with similar issues to those that have been raised today, particularly early on there was a contribution saying try not to do everything. It is an absolutely huge agenda, and we have been grappling with this in Wakefield. So the first key kind of area is how do you prioritise the work that you're going to be doing as a system, and then how do you divide it up between working at a West Yorkshire level, how do you do it, what do you do at place level, what do you do at an organisational level. So these are all the issues that we've been kind of grappling with really on a place level. The issue of GPs was raised, primary care network development, the MDTs, the additional roles and responsibilities is something which is a key part of our plan. How does the VCSE, how do carers feed into the workforce? So how do we define our workforce moving forward? Areas like dentistry, which often are neglected within workforce plans, how do we incorporate those? Co-production with staff, I think somebody raised that. I think it's absolutely critical, as they are our workforce, that we fully engage with them on development and implementation of the strategy. And then the inclusivity agenda, ensuring that we make sure that that our workforce reflects the community which we represent, and that we treat everybody with respect and dignity. So all of these things we've been grappling with. And what I thought today, rather than going into detail on the Wakefield People Plan, is first of all to highlight some of the key characteristics of the way that we work in Wakefield. And that's been evolving over the last 3 to 4 months. How we identified our joint priorities. We're now moving into the delivery phase, so our people plan has been approved, signed off by the Wakefield District Health and Care Partnership. That was done in September. And what we want to do now is make sure that we do deliver and that we identify what it is specifically we want to achieve, certainly by the end of this year. So we're in that process at the moment. So in terms of background, I know that Linda and Phil, who are our joint SROs, are absolutely committed to making sure that this is as an inclusive process as possible when we're developing the plan. And I think we have demonstrated that through the work we've done through the Alliance. We've also tried to ensure that there's been full ownership of participating partners by the pillar leadership approach that we've adopted, where we've actually identified leaders within the system from across organisations to drive forward specific initiatives. I think that is an important key characteristic of the way in which we worked. We have a People Alliance, which hasn't just been set up as a one-off, but it is actually an evolution of our HRD network that's been in place for a number of years now. So we've got those relationships between both our HRD departments, but also between our senior leaders across service areas, so that they can talk about how our workforce needs to shape up over the next few years. We've got agreement to joint investment into a programme management office, which is designated to just work on a system level. There's £370,000 recurrent that's been committed by 4 organisations within Wakefield, which will help us to implement and deliver on the plan and work alongside our pillar leadership. We've got the pillar leads. So as I said, we've got 2 pillar leads for each of our major programmes, of which there's 6. That's 12 pillar leads. And they are all good system leaders who have been specifically selected for that reason and are immersed in that kind of area of work. There's the Gorse Academy, which is one of our key programmes that Phil will come on to, but that will, we think, transform our approach to training and education. We've also been, I'm not sure whether we've successfully navigated, but we are committed to navigating the interdependencies with our other transformation programs. So we are trying not to operate in isolation. We're trying to link in with our Connecting Care Alliance, with our transformation program around planned care, around urgent care, making sure that all the workforce elements of that are reflected in the work that we are doing and that we support them with that. And then finally, we think we've got a plan which is a focused work plan and which isn't going to be pushed around because of the changing environment we're working in. It's got to be flexible enough to respond to new national initiatives and to the pressures and the fluidity of the work that we are doing, but it has to be focused. And we have to make sure that we deliver over the next 2 years, so we are committed to that. So the 6 pillars of our plan are consistent with the West Yorkshire one. I won't go into these in any major detail because I'm sure you're aware of them, but they encompass all the different elements of workforce that were covered by the West Yorkshire plan. So on looked after people, we're looking at physical health checks, mental health first aiders, post-COVID support particularly features within our looked after people pillar. On growing system leadership, I think the debates around there are what actually is system leadership, what are the competencies that are required for decent system leaders, and how do we support that and promote that over the next few years, because it's going to be absolutely critical. Belonging is, as we've already alluded to, mainly around the equality and diversity agenda to make sure that our workforce reflects the community that it serves. On new roles and new ways of working, I think a particular focus this year for us is going to be around the networks, primary care networks, and the new roles that are emerging in the community and in social care, around domiciliary care potentially, and even our informal carers too. Can we develop and improve the levels of skills in those areas? Growing and developing our workforce is a critical one. It covers things like international recruitment. It covers the academy. It also just looks at where there are issues of vacancies in the workforce currently. And then finally, there's an opportunity for us to plan our workforce on a system level. It's incredibly complicated, but it is something that we are looking at and we want to try and cover off as part of Pillar 6. So we have, as I said, pillar leads for each of those areas who are directly accountable for delivery of the programmes. So in terms of our vehicles for delivery, we've got 3. So we have the People Alliance, which is already established, as I said. We have a PMO, which is fully dedicated to delivering the plan. We have our pillar leads, who are directly responsible to the People Alliance for delivery of those plans, supported by the PMO. And then we have a workforce hub, which is the way in which we socialise our plans and socialise the strategy, so that people, which we think is a big issue, about awareness and visibility of what we are doing on workforce to make sure that we get the message out there. That's it.
Hello. First of all, a couple of thanks. Thanks to the ICB for giving us the opportunity to bring to light the people plan and to talk about that. So thanks to Kate for the invitation. My other thanks to Joe Webster for this session, because Joe's enabled me to navigate some relationships within local authority and education to bring us to the point of where we're at the moment, and that's been really invaluable. The proposal I'm here to talk to you about is the fact that we have now submitted a free school application to serve the Wakefield Place for health and care. That is a physical build on the Pinderfield site. We've been working with the GOS Academy group, who work extensively across Leeds in areas such as Bruncliffe Academy, John Smeaton and Elliot Hudson, to name but 3 of their organisations. So we've partnered up with them to submit the free school application. That was more or less a 35,000 word dissertation that we've been working on during the course of the last 9 months, which we submitted on time on the 30th of November. And then since the 30th of November, we then had to liaise with the local authority for them to submit a supportive bid, because without a local authority supportive statement, the bid would be dead in the water. So this will be a post-16 education provision, which will specialise in health and care qualifications. A brand new purpose-built facility on Pinderfield site using government capital from the free school bid process, run by the Gorse Academies Trust, but in partnership with the Wakefield Place. It will open hopefully in September 26, first students to matriculate in the summer term of 2028, and we're envisaging between 250 to 300, but we would push that out to 700 students in that academy across 2 years, all focusing on T-level qualifications in either health care or healthcare science. I've been driving this personally with a team from mid-Yorkshire and working with the Gorse Academies Trust. I think for the last 7 months we've been either at John Smeaton College or back within mid-Yorkshire working on the bid. And it's my drive really to have a clear line of sight to our future workforce. Where is the future workforce going to come from for health and care in place? We're only as good as each of our respective parts, and wouldn't it be great to have people training in all of those places and rotating and have a genuine career choice at the end of that? So this is absolutely aligned to the people plan. If I just change over the slide to the curriculum. So at the beginning of the 2-year journey, people undertake programme, young people will undertake a programme in values in health and care. They'll complete their care certificate and they'll complete NHS and social care mandatory training. And importantly, this is very different to work experience. This is work placements. So 45 days across 2 years they will spend in health and care organisations having the practical experience to complement their studies for their T-level qualifications. And there should be no restrictions in any organisation for where we can deploy students. Obviously we'll risk assess some areas, but in the main, everywhere it will be there to help inform their future career choices. We'll also have some digital skills training in there as well, and part of our partnership with Gorse Academy is to work with them on the new math school in Leeds to support some of their students coming out from grad and IT to work in a number of areas across health and care. So if you look at the career pathways as part of the bid, we've had to work very carefully on the future career pathways. So they'll be able to enter employment. Every single student that comes out of that organisation will have a guarantee of employment. And during the 2 years of their studies, they'll also be given a bank contract so they can earn as they learn. And again, that will help people retain locally, hopefully drive up health inequalities and support that by making more financially well-being families and young people across the district. So guaranteed employment into entry-level roles. But when you think about the possibilities, and it's been fantastic spending time with the Gorse Academy group about the art of the future, because if you look at nursing just as one example, you know, people can drop off at the end of their T-level qualification and become a healthcare assistant. If they want, they'll have the requisite qualifications to go on to become an apprentice associate nurse, or indeed they could go, for example, to the Dewsbury School of Nursing or Bradford or other universities using their T-level qualifications as a direct entry route, and that's just nursing. And as I say, this is across all disciplines, both professional and registered professions and non-registered professions as well. And we would offer significant targeted support in year 12 by our staff going across from health and care to really influence career choices, hopefully in health and care for those young people. It's absolutely aligned to the strategic aims of a number of organisations, the ICB itself, the Wakefield People Alliance, to grow our people and have a sense of belonging, but also the Wakefield Employment and Skills Strategy. And I've spent a lot of time just recently with local authority colleagues on their supportive statement for the bid, but it's absolutely aligned to their strategy and employment skills strategy, which, as you can see there, it states improving educational outcomes and skills levels within the population of Wakefield and grow the health and care workforce. So absolutely aligned to each of those 3 strategic aims. Just some of the benefits, I won't dwell on all of these, very difficult to read, sorry about that, should have been a bit bigger, but from an equality, diversity and inclusion point of view, we're overall in our recruitment process, and one of the key attractions for me of working with the Gorse group, because this could have been with anybody, but is their track record on opportunities for disadvantaged groups. And again, we really need to be flexible with our entry criteria into the academy for people who want to take up that opportunity. And we just talked in this meeting about retention. You know, health service staff stay, and I talk more about retention and recruitment than the old language of recruitment and retention, because retention is really the key point. But a number of people who are contemplating retirement are absolutely fantastic educators, and there's so much opportunity here for people who want to step down towards retirement to be educators of these 700 people, either in the academy itself or in the workplace settings. And it doesn't need registered staff to be educators and trainers. Our healthcare assistants, a number of our non-medical staff are all able to educate on a number of different roles across the organisation, because NHS staff love teaching, and teaching means people are retained. So I'll just move on. The application process, it's been very difficult. I'm delighted we got across the line. We've had engagement with local stakeholders, MPs, local authority leads for children's services, education and inclusion. And I've also taken personally the time to speak to Outward Grange, to Pontefract New College, to Wakefield College, and we'll shortly be speaking to Kirklees College, because I didn't want this to be seen as competition. To some extent it is competition, and I'm shameless about that, because I want people to have that choice of a specialist qualification in health and care to come and work in the NHS or in care settings, but equally I want to offer a number of placements to all of those organisations as well, because we need as many people as possible come into health and care in the future. And I'll be attending the board strategy day at Wakefield College to help inform their future choices about educational provision with a slant, hopefully, for health and care. It's been supported by the Mid Yorkshire Trust Board. That was supported on the 10th of November. It's been supported by the People Alliance. And we're now waiting to hear the next steps. The next steps, hopefully, we'll hear in spring. And if we are successful, I understand that despite 200 outline applications of interest at the beginning, 65 applications have been formally submitted, with a potential for 15 of those to be funded nationally. So we have a 1 in 4 chance of being successful. And between now and the 23rd of January, I'm mobilising as much support as I can do by way of letters of support, and I hope I might be able to encourage ICB board colleagues to submit a letter of support for this as a proposal going forward. So we'll absolutely utilise this space between now and the 23rd of June to try and get those final steps. It was good that I've had some interest from other areas. There's a parent governor who works in Bradford District Care Trust, who is a parent governor at the Gorse Academy Group. There's a newsletter being issued by the Gorse Group talking about the relationship with the Wakefield Place, and that stimulated interest in other places, and I've been invited to go and talk to 1 or 2 organisations about what we're doing in the Wakefield Place. Just in the interest of time, I'll probably stop there. I really am hopeful that we will be successful in this. I'd love to keep the ICB abreast of this. It's a great initiative for our ICB and our place. Thanks very much indeed.
Thanks very much, Philip. If you're okay, just that's it. Thanks to your microphone. If I go straight over, thank you for that. I'm sure there'll be some questions at the end. Bradford District and Craven People Plan. If I can introduce Daniel Hartley as the Director of People at the partnership, and Professor Karen Stansfield, who is our Dean and Professor of Health Leadership at Bradford University, who'd like to take us through this pictorial, which you do have in your slides if you can't see this. Thank you, Daniel.
Thanks very much, Kate, and great stuff, Philip. Really good stuff to see what you're doing in Wakefield. So, and Mid Yorkshire. So, what I want to just touch on is a little bit about the what we're doing, a little bit about how we're going about it, and who's involved, plus a couple of specific examples of things that we're making really good progress on. So, first of all, and there is just the one slide, I suppose. What I would say is that since I joined the Bradford Place last April, what we've really done is recognise that workforce is one of our top priorities. It's not just an enabler of our priorities. So I think that's really important positioning, and a positioning I would encourage for us to think about across the whole ICB. Our people plan set out here mirrors and supports the West Yorkshire ICB people plan, and is completely aligned in all respects. And we're working really closely both with colleagues in the other places and also Kate and your team, and thanks for your support on the things that we collaborate on. There's a footprint in the top right hand corner, because some of this, and I was struck by the conversation earlier, some of this is working out what the added value is. I suggest at the different levels, this isn't just an aggregation of everything that is going on in Bradford District and Craven. There are lots of actions for employers, there are lots of actions for individuals, etc. So what is the sweet spot? What are the things that we can do better together? And some of that, a lot of that is at place, some of that is across the whole of West Yorkshire. So what's really important is we've got Chief Exec sort of ownership of this for Loke Ajayi. The Chief Exec of Airedale Foundation Trust is our Chief Exec lead. We've got Karen and myself, which we think is a unique combo around England to have a sort of university and a place people director partnership. And then the pillar leads, if you like, they're the HR directors of our 3 NHS trusts and Bradford Council. What they then lead are really inclusive leadership groups, completely representing colleagues from the independent care sector, local authorities, FEHE, VCS colleagues, etc., etc. We've also done broad engagement with colleagues from across health and care to make sure to get their input into this and to say, well, what matters to them. I think we've got an opportunity on the NHS side of the house when we get the staff survey results shortly for the last year's survey to say, well, what are the problems we can solve together, hearing what people have said, because there is clearly a number of commonalities. You pointed earlier, colleague pointed to the learning piece, for example. So what can we do together? Briefly then, I won't go through all of this, but what I would say is that in terms of the looking after our people, what we're doing is very much expanding our focus on the sort of health and well-being side of things to focus very much on retention. So what is the evidence base? How do we segment our workforce? How do we treat people how they want to be treated, not how we think they want to be treated? And perhaps I was struck by your point, Tom, earlier. I think there's perhaps something about us thinking about what capabilities have we got across each place, whether it's knowledge, it could be skills, could be experience, could be levers of policy change, etc. To say, well, what could we do? We've had discussions with the independent care sector to say, what are the opportunities on international recruitment there? And, you know, given the, in inverted commas, loss of staff to the NHS from that sector, my proposition is that's less of an issue if it's more predictable, and if we can routinise that, so that's a particular thing we're looking at. In terms of leadership, inclusion and belonging, loads of work, as you would expect, on leadership and inclusion absolutely is across all the protected characteristics and other forms of inclusion. To the earlier point, when we talk to staff, people are interested. People are already working with colleagues, aren't they, from lots of different organisations, typically across the place. But we need some help to show actually how all health and care services support people, because people do think often of the big buildings, don't they? The local authority, city hall, or the county hall, or the town hall, the hospitals, etc. But what about all the other organisations working deep in our communities? So we're doing some work on a Act as One experience to bring that to life. We're then really working hard to make the other priorities a success. So the other piece, and we haven't touched on this so much, is perhaps how our people with workforce expertise align themselves to our other priorities to make sure that we are shaping proposals that are going to make a success. And a concrete example would be virtual wards. How are we designing that in a way that aids retention, that gives opportunities for people to become legacy mentors or support staff, etc. I'm conscious of time, and I'll hand over to Karen. I just would make the point that we're doing lots of work on the digital sides of things. So we've got Bradford Cares website, we've got our oneworkforce.org website. We're experimenting with geofencing in terms of the following people around on the TikTok adverts to try and engage with a different new generation of people. And we're also, we've got big outreach programs targeted at schools in deprived communities, etc. So with that, I'll pass to Karen.
Okay, thank you, Daniel, and thank you, Kate, for the opportunity to present today. Excuse me. Sorry. So two of the key areas is around developing new ways of working and growing the workforce, and that's a particular interest because all universities are in the market for supply, and I see very much this pipeline and working in Act as One in this way has really enabled us to align number planning and placements. And I think talking about priorities, placements has to be the priority going forward. We're really looking that we've got fantastic relationships with our partners in Bradford, and we've been able to, and broader, and we've been able to look at how we can map successfully and do things differently. So we have connections, so there's staff members from BTHFT who are working with HE in partnership to look at new ways of midwifery delivery, because as somebody said earlier, it's not just about the placement, it's about how you deliver the supervision. So coaching models enables you to develop much more capacity within your placements, and it's something that has developed well but could develop further. So I think that joint work there is an area that's doing just that. Other things, talking to Rob earlier about, we've got digital students who are out in placement, they get the placement, they also get the opportunity then to do dissertations into areas that are really important to place, and the same for our public health colleagues as well. I think other things that we've looked at jointly, because we are a university, is things like care certificates. So we talked about how could we improve that and make sure that all our undergraduate students have the care certificate embedded into their programme. Things like virtual wards, somebody mentioned earlier. So as soon as Daniel and Place started talking about virtual wards, we were saying, what about placement capacity there? How can we enable the students to be part of that? So I think there are lots of different areas that this sort of connection has enabled us to work on. I think the other thing I would say as well, from a university perspective for all universities, there's also a demographic in universities where that workforce of people who train and deliver education is also shrinking. It's becoming harder across place and across West Yorkshire to recruit into universities, and that's for all, not just in Bradford. So I think there's something about how do we develop that, and initiatives like Philip mentioned as well, how you're growing that pipeline and finding new roles. So we've been talking to local partners about, instead of people, we know if you look at the NMC register that people are retiring earlier, yet we know that people want to work in different spheres. So we're looking at how can we make secondments easier, how can we do things differently and have more fluidity across place, and also how can we make it more fluid in terms of universities not just being about delivering and creating knowledge, but also about treating patients in our new imaging suite that we've been working very closely with BTHFT and Place. So I think I'll end there for time, Kate, but we could go on and the different things we've done.
Thank you to you both. I think that's been really helpful just to give that good overview, and particularly, as you rightly both say, that link with our higher education institutions. Our last area, let me just press, is it working, the button? Yes, it is the social care sector. I've invited Louise Beswick, who some of you will know is the Chief Exec of Bradford Care Association, and I'm sure many of you know Richard as Strategic Director of Adult and Health in Kirklees. There are a few very short but additional slides here that weren't in the packs, just to set some context. If I hand over to you both, thanks very much. Thank you.
Yeah. Thanks, Kate, and thank you very much for inviting me. I really appreciate it. So just to set a little bit of context, I'm here wearing a number of hats. So I am a care home provider, until recently a domiciliary care provider, and I'm also here representing the Yorkshire and Humber Care Association Alliance. We formed that group last year in 2022, and that is basically what it says on the tin. So it's a collective of local care associations across Yorkshire and Humber who've come together really to see how we can work better as a region across the sharing good practice, supporting providers, etc. And we're also sort of, if you like, a subgroup of the Care Association Alliance, which is a national grouping. So what that enables to do is to work locally, regionally and nationally to support care providers and share that good practice. We are represented in West Yorkshire specifically in the 4 places, so we do have a gap in terms of Calderdale, but we are working with Calderdale to see how we can support them to establish a care association and develop those links as well, and represent providers well. In October this year, obviously we talk about crisis, we talk about unsustainability, we talk about workforce issues, and for social care, it is, it really is reaching that crisis point. So as a group of associations, we decided to create a call to action, and that went out to elected members, local authorities, NHS colleagues, and social care leaders, to invite them to a meeting, a virtual meeting, to sort of really highlight some of the critical issues that we're facing, actually, the immediate issues that need to be taken and some of the action that needs to be taken from that. We see, time and time again, there are lots of discussions that happen, but unfortunately, sometimes that doesn't always lead to action. And we don't have the luxury of time anymore in social care. We are seeing the number of providers dwindling quite rapidly. And with that, we're losing workforce, which is absolutely key. So that meeting was a real success, and there was a real collective eagerness to actually do something, at a regional level, a place level, and obviously an ICS level as well. So we've developed the 10-point action plan, which Richard will go on to talk about a little bit later. But just obviously to give you some more context to the social care sector, you can see we're just referring to here some of the vacancy rates. The national vacancy rates have sort of increased by about 50% in the last year, and we're sitting at about, I think it's 101.5 million vacancies, 1.5 million people, working in social care, with 165,000 vacancies. And that is a deteriorating picture. And across the place, we see that we've got a high vacancy rate of 12 to 13, particular pinch points being that of registered managers, nurses, and also domiciliary care staff, which isn't broken down there separately, but because of the challenges we face around making sure that workforce remains mobile, we are particularly struggling to recruit people into those areas and becoming more and more reliant on agency staff from there. Going on from there, you can see there we have over 2,000 registered managers in the region, in West Yorkshire region. And I have to say that they are really the guardians of social care. They drive the culture, the quality, the recruitment, the safety of all those organisations. And from my point of view, they are seeing an increasing workload with very little systematic leadership support and development, and they are people that we really need to support going forward. We are seeing really high turnover rates, And then obviously we're also seeing that a large proportion of those, in terms of the demographic, is an ageing demographic, and we need to look at encouraging new people in there. And when we talk about new placements and new opportunities for education, it's actually about developing those programmes to bring forward the registered managers of the future as well. And although we are seeing recruitment increasing, as you can see from there, what we're also seeing is that actually it's not keeping up with the growth of the sector and the demand that we're seeing within the sector. So we need to do more to fill these posts going forward. You'll see from this as well, the majority of our workforce are female. You know, in terms that presents opportunities and how can we, you know, expand and invite more males into the workforce. But what we also have to highlight, this slide doesn't, and there is unfortunately the data to bring this up, is actually a significant proportion of our workforce are in receipt of benefits and are in rented accommodation. So the cost of living crisis has an absolutely huge impact on them. And we're not being able to attract that younger work grouping into the workforce. And we're seeing, you know, many challenges around international recruitment. Some providers are taking on that challenge of registering for that, but there are significant barriers in terms of cost and just general good guidance and advice to that. And we really need to do what we can with international recruitment. You will see from here that obviously the EU, we did previously have quite a number of EU posts within social care, and with Brexit we have seen that deteriorate. So we need to focus on how we can bring more people in there and ultimately encourage more people into the sector. There are challenges around some of this, in the fact as well that the majority of our providers up and down the country are small to medium providers, and what you have is about 15,000 providers providing care at 17,000 locations nationally, so it's really hard to coordinate all of that. So some of the challenges aren't dissimilar to what you're facing other health and care sectors. So you know, challenges around the role of registered manager. As I say, it is becoming an increasingly challenging role. They need more support. They drive the recruitment and retention within the workforce. So we need to do much more to support them if we need to take this forward. The nursing workforce is a huge size, you know, certainly, you know, equivalent to that of the NHS. And again, what can we do? What are those career pathways, both in and out of social care? Because it's actually crucial. You know, we talk about that retirement or people's changing and going for secondment, etc. Are there opportunities to explore that further? Domiciliary care is, I'm sure all places will recognise as a huge challenge, and trying to maintain and keep a mobile domiciliary care workforce is ever increasingly challenging. And we are, you know, they're struggling people to access, to be able to drive, to access vehicles. And we are seeing, unfortunately, in terms of retention, a real pinch point here because people are having to make the difficult decision to leave the sector from that point of view. And the cost of living crisis, as we are saying, more and more people, unfortunately, are able to go and earn more money working in their local supermarket. Even with the national living wage increase, you see, we then hear the Sainsbury's and others are making, you know, the decision to increase their basic pay rate to £11. We are struggling to compete, and we need to do more. There are increasing business failures, and every time we're seeing a business failure, we're seeing staff exit the sector, and we need to do much more to prevent that. And there are other things, you know, talk about looking after our people. You know, what can we do more to support those, retain them, occupational health, mental health support. As individual small businesses, they will struggle to do that, but actually, as a system, we could collectively do more to support the people that we're looking after. In terms of some of the core activities around, there are, you know, what we're needing is to look at a One Workforce campaign. Now, there is the national campaign, but we need to do more on that to actually see what can we do locally, what can we do across West Yorkshire and at places to recruit people in there. Can we have a local recruitment campaign to attract people into the sector and to showcase what they can do and the possibilities, because it's not just care roles, it's domestic roles, it's activities coordinators, a whole vast array of roles within the sector as well. International recruitment we've already touched on and the opportunities that presents. Training, you know, we need that support from the West Yorkshire care sector to look at prioritising training initiatives. We can't do everything. It has to be accessible and it has to be sort of resourced and funded for providers. And we must prioritise. We talked about prioritising some of the work that's done, but we have to prioritise the training as well, because they can't do everything at once, and we must look at embedding this and enabling registered managers to actually take full advantage of the training that's on offer. Placements are a vital part of that, and we're already exploring in detail how we can do that. And just by opening up that care certificate as one main opportunity for people, and we're already seeing that people who are studying at Bradford University are undertaking care certificate and then doing, undertaking work throughout their studies actually in care sectors, which is, it's a fantastic opportunity to gain that experience as well, and knowledge and understanding of the sector, which they can take forward into their future career. Moving on then in terms of data, yes, we've talked about data, and unfortunately data for social care is lacking. It's improving. We've got the mandated now capacity tracker, but actually more needs to be done to how we can do that. But also there is the burden of data collection. So how can we do that well and once and actually save some of that burden for providers without an additional ask in there as well? The detailed care sector workforce planning is an absolute must, and we see that immense detail in the NHS. We need to see that replicated for social care, and I know that's something that is being looked at and worked towards. And then just in terms of a communication campaign as well, we need to enhance that profile. So as well as sort of increasing the recruitment and trying to do a recruitment campaign there, we also need to do more to actually just raise the profile of the sector, improve that recognition and respect of the sector so we can attract people in, because unfortunately all we hear is a lot of negatives on there as well. And then here, I'll pass over to Richard, who'll talk about sort of from this regional grouping, how we're actually trying to align ourselves.
Thank you, Louise. So this was produced as a result of that call to action meeting that Louise talked about earlier. It's been developed primarily by the care associations, but with support from ADAS across Yorkshire and Humber. ADAS represents Directors of Adult Social Care. And uncannily, although this was produced last autumn, we've gone on to talk about almost everything that was in this today. It's worth noting that this is a regional approach, but I really appreciate that we've got a fantastic ICB people director kind of representing and leading on behalf of all the ICB. So thank you, Kate, for stepping into that space. I know that you're into some very interesting conversations with colleagues across other parts of Yorkshire and Humber about, well, why would an ICB be interested in the social care workforce? Well, I know the DAS has really appreciated your input to date. And there's a number of other West Yorkshire colleagues who are part of that kind of Yorkshire and Humber arrangement. And so we really see that taking this activity forward, we need to operate at a number of places. We definitely need to operate at neighbourhood because social care is very, very locally delivered. We need to operate at our places because if each of our places has a specific social care market, there's very much just something about what we can do once across West Yorkshire, but a number of those things need to step up and operate at a Yorkshire and Humber level, because we have a number of provider colleagues who actually operate across boundaries. Actually, for them, being able to tap into a consistent approach is really, really helpful. So I think it's probably good that we pass over now for questions and comments.
Thank you, Richard. So I think that comes to the end of our presentation. I'm sure you'll all be pleased to know. Hopefully you found that really informative. I hope what we've shown today is a bit of a journey, firstly, of a sense of the size of the workforce across the system, some of the challenges in terms of, let's be honest, the gaps, the workforce gaps that we've wanted to cover, and then starting on a bit of a journey in terms of what we're doing about some of that, both in terms of the integration of our approach at system level, workforce planning and new ways of working being two examples, but there are many more. And then thank you to my colleagues here today. You've heard examples of this can't all happen at West Yorkshire level. It doesn't need to, because actually you're all so active in this. So both in terms of two great examples of place, and then thank you to our colleagues in social care as well. So without further ado, Cathy, I'll hand over to you. Thank you.
Thank you very much. So Jonathan Gaynor, Philip, Dominic, Karen, Daniel, Louise and Richard, thank you so much. And Richard, just as you were talking at the end, I think this is a really lovely summary slide. I don't know why I used the word lovely, but all those points in green were raised with us in some way at our engagement session with colleagues this morning. And I was pointing out to Rob the commissioning reform, which actually perhaps is not so much we've talked about, but I think it's a really helpful slide to work from. So thank you for your contributions. And I know there'll be other colleagues who've helped you prepare for today. We've now run out of time. So that's how fast that time went together in looking at our first introductory session on workforce. And thanks again, Kate. There's lots to do. I think there's a theme around prioritisation, around business intelligence, data, quality placements, digital enablement, international recruitment, which I know you're working with Rob on at the moment, and the word ethical that sits with that as well, but that broad way in which we need to look at health and care roles and professions across that, and making sure that we're inclusive of all sectors and professions, and this mitigation of competitors. We just talked about the supermarkets being our competitors, and that's what we heard from colleagues who we met with this morning as well. And then the wonderful work that's going on in Wakefield as well, Philip, thank you. So just let us know if you need a letter. I'm sure there are lots of people around the table to help you. So there's a huge amount there, and I'd really encourage you, Kate, perhaps, as we did with primary care today, if you come back and maybe take 10, 15 minutes at the next meeting, give us an update, guide us on priorities, come back with any asks. And Kate and I have already had a chat this week that we'd make sure that this is a focus on topic for us within the next 9 to 12 months as well in one of our meetings. Rob, do you want to reflect?
I was just going to suggest that we ask the People Board to do that. Yeah. And you know, take all of the fantastic insight from today. We've got the People Plan, we've got a People Board. Yeah. Let's use the Partnerships People Board to do it. I think the only other reflection I would have is that this is a leadership challenge, isn't it? So we hear that it must be horrendous to work in health and care at the moment. There's all sorts of stuff in the media, but the people that we spoke to earlier painted a different picture. You know, one where they're having the best days and the worst days on the same day. And how do we make sure that we are delivering improvements and a better future for them and giving them some hope? I think what I've heard around the table is there's lots of leaders who are involved in developing realistic, credible plans for improving the workforce. And if we can build on the fantastic culture that we've got, I'll just repeat one of the stories we heard this morning, where a care worker told us that she didn't see her children for 6 months because she was isolating, because she had a duty of care for the people that she was supporting in the care home. Well, that's during lockdown. So that's the kind of culture that we're dealing with. People who are hugely committed to the work that they do, and if we have the infrastructure to support them, is what we've just been talking about. And we invest in the right things, then we can build something which will be significantly better. So I think that's what we've got to do, and I think the People Board is an opportunity for us to get that right.
Great, thank you. So we'll hand that over to the People Board. Majid, I know you non-exec with that remit as well in working with Kate, which would really welcome your support on. And again, thank you. This isn't just a one-off. This is a continuing conversation and a continued commitment as well to support the good things that are already going on and the proposals you're making to remove barriers or develop new opportunities and innovate as well. So thank you for all your perspectives. So colleagues who presented, feel free to go. We're going to take a break now. We're going to end the live stream at this point, pause it, should I say, and we're going to come back in 15 minutes. So board colleagues, very welcome to go and take a comfort break now. And we'll come back at 10 past 3. Thank you. Welcome back to the next part of our NHS West Yorkshire Integrated Care Board. We have just finished our session with a focus on workforce, and thanks again to all the colleagues who presented today. And for anyone watching on the live stream or afterwards, all the information is available online, including our People Plan and the specific document in item 10 in looking at our workforce. We're now going to move into our oversight and assurance section of our board meeting. We have my report as chair and then our chief exec's report, and then we'll be hearing from Laura on our developments with our board assurance framework, which is good news. For my report in item 11, it is as usual a update on our strategy, policy and governance work that's taking place. I particularly want to note Julian Hartley moving on as Chief Exec from Leeds Teaching Hospital at the beginning of next month, and thank him for all his contributions to the system, partnership, LTH and including our board, but also welcome Brendan as our interim board representative from Calderdale and Huddersfield Foundation Trust, representing our acute sector. Was a number of things within my report. One is on the Hewitt review, and Rob will touch on this as well later in our submission, and thanks to our strategy team for working with us. It was a tight deadline, including Bilal in our strategy team, who worked very long hours to put our submission together. And in the spirit of openness and transparency as we undertake in our partnership, all our information and submission is online that you can go and have a look on our website. And thank you also to Karen Coleman and her colleagues for making sure that the information was there on time. And we've shared our submission with the Hewitt Review with our NHS England Regional Director, the Chair of NHS England, and colleagues at the Care Quality Commission as well, which have prompted some really welcome discussions in taking ways of working forward. You'll also see an update on the strategic plan, which Ian will cover later in item 19. I also want to continue to highlight the risks around the sustainability of voluntary and community sector and the work that Kim Shuttler and our Harnessing Power of the community are doing at the moment, which we'll come on to, I'm sure, later in our corporate risk register. And also our work in profiling and supporting all our colleagues in the NHS who have capital bids and needs at this time. You may cast your memory back. I wrote to the then Department of Health and Social Care Minister Robert Jenrick from our September board meeting on our needs across West Yorkshire, and we're pleased to gain a response from Lord Markham's office recently into that, and we're just exploring opportunities at the moment and providing further information. You'll also see in the report on our integrated care partnership development, specific ways of working with our local authorities, NHS and voluntary and community sector, and that we've put together a working group of colleagues to look at how we develop our partnership in line with our statutory arrangements without losing the ways of working of many years, including our behaviours and values that we hold together. Those of you remember, we had a board development session back in December, which we held online, which felt appropriate that day due to industrial action. But again, it was still a really helpful session on board effectiveness and looking ahead to our annual review of governance. And our February session will be at the Crescent in Batley, which is a community venue, has a food bank operating out of that. So we'll have a session there, particularly looking at our role as a commissioner and beyond that for the new financial year, but also we'll get to meet that particular community centre. So there's a number of highlights there. We've also been award-winning since the last time we met, including HSJ Awards and particularly national recognition for our Root Out Racism campaign, which is a fantastic accolade for us. So some highlights for your colleagues. There isn't anything to gain approval on, but it's just there for information and assurance. But I'm happy to take any questions if anyone has any. No, I'll take... Oh, Jane.
Yeah, Cathy, thanks. Just one question in terms of interesting the Hewitt review and then the Health and Care Select Committee inquiry. Just wondering if there is how those two sit next to each other, complementary, different angles, or how does it feel for those who've been engaging with the two reviews? And
Thank you. I'm going to hand over to Rob, because Rob, as you know, gave evidence to the first session of the Health and Care Select Committee and also sits on the National Hewitt Review Advisory Group, which we're really grateful for. So, Rob.
Yeah, so I gave evidence in the same session as Patricia Hewitt prior to her being asked to do the review, and we were asked explicitly about accountability and authority of ICSs. So I'm not sure if there was a direct connection between her giving evidence and then being asked to do the work, but the themes and the evidence that have been presented to the Select Committee are very consistent with the conversation and what looks like the evidence submitted to the Hewitt Review.
Great. Thanks, Rob. That's really helpful. And you're continuing your involvement with that group, and Patricia Hewitt's report will go in March. And we're pleased to receive acknowledgement of our submission, and we've been keeping in touch with other systems as well to compare and contrast submissions and information that's been shared on that. Okay, so we're going to move on, Rob, now to your report, item 12, the Chief Exec's report.
Thanks, Cathy. So in the interest of time, just take this as read with a few updates. So on the industrial action, there has been no conclusion or resolution to the industrial action and the dispute between the government and the trade unions. We hope that there will be at some point in the future. To say that we've also been successful in managing the consequences of the industrial action over the period since we last met, and we have some forthcoming industrial action. The period between Christmas and New Year and into the New Year was particularly difficult because of a number of factors. You may recall a while ago we had a conversation about what we thought would happen in that period because of respiratory illnesses, and the fact that the Southern Hemisphere had seen an early and very sharp flu season, that we were expecting another wave of COVID potentially and some other respiratory illnesses, and that would put some significant pressure on our services. over and above that, we've had the industrial action and we had the Strep A issues, which we did not expect at the time. So you can imagine the degree of challenge in the system has been substantial. What I can report to the board is that the response from the EPRR teams, the places and the organisations has been fantastic. And throughout the period, we've had daily conversations at system level and place level and within organisations several times a day. And during the industrial action, we've had 24-hour reporting and monitoring of the situation, including overnight. So I want to say thank you to those staff who worked overnight in the control rooms, particularly people like Kate and Anthony, who did some of those shifts. Bev, I don't know if you want to say anything about the industrial action that's taking place this week and the arrangements for them so the board's aware before I move on to my next update.
Yeah, thanks, Rob. So the board will be aware that the Royal College of Nursing are taking action tomorrow and the day after. Within our system, the ICB has been called out to strike. We've got 206 registered nurses within the ICB. We don't know the exact numbers of the people who are in the RCN or how many plan to strike. We won't know that until tomorrow. We've got a full command and control structure set up, starting from this evening, going over the next 2 days, and then it ends on Friday, where we have a wash-up at region. And we've got a battle rhythm that's set by the centre, the national team. So we've got each place represented on our strike committee. We've got with invitation to the wide system at the West Yorkshire level, and myself and Anthony will be managing the regional meetings. We don't anticipate any issues. There will be no derogations because of the services that we provide at the ICB, but we plan to continue with that battle rhythm in any case. Thank you.
Thanks, Bev. So just to give people an indication of the kind of work that we might get ICB nurses to do, it's continuing care assessments and issues like that, which will be distressing for families who have things that are postponed but can be managed across a broader time frame. There will be action taking place in South Yorkshire and Humber and North Yorkshire, just to remind board members that the RCN and other unions have decided which institutions which have balloted successfully to strike take action. So over the next 48 hours, we will expect some of our South Yorkshire and Humber and North Yorkshire colleagues to face some pressure. That may have some knock-on consequences both at the border and with the ambulance service, because we have a regional ambulance service, which will, if there are problems accessing sites, then cause delays which may impact upon services in West Yorkshire. But we'll keep that in view. So it's worth us noting, I think, formally as a board, thanking all partners and all staff for their work over the period. And I wrote to everybody last Friday to say thank you. In this context, we're seeing the new operating model, which is focused on devolution and planning guidance, which reinforces that. That's outlined in the paper. Just to confirm that the meeting with the Secretary of State, myself and Cathy, which was called before Christmas and cancelled on a strike day, has not been rescheduled yet. Every integrated care board is meeting the Secretary of State or a member of the ministerial team, and those meetings are expected to continue into the future. The paper reflects some elements of good practice and highlights that Leeds was successful in bidding to be a front runner for integration. And I don't know if, Tim, if you want to say anything about the Prime Minister's visit to Leeds last week.
Yeah, thank you. So, as many of you will know, and still it remains a challenge, Leeds has been quite challenged around discharge and broader system flow for a period of time. And probably back last April, we, as well as continuing to do work that we needed to do in an immediate sort of operational and tactical level, recognised we probably needed to do some broader work as a partnership and to get a partner in alongside us. and we went out to a procurement and through a procurement process. And whilst we were doing that, we were in ongoing conversations with NHS England colleagues over those months, as you'd probably expect. At the end of that, in July, Newton Europe were procured to come and work with us. And we were asked to apply for the sort of integration programme, which was particularly around discharge, as colleagues will remember. It all then went very quiet. I think everyone thought it maybe had gone away, we weren't successful, that's sort of how it was. We continued with our programme, and then back in perhaps early November, late October, we were asked to then pitch again, and did so. We were then, so we're now one of the 3 sites across England that are going to effectively pilot, I think, from their point of view, a new model of intermediate type care and around discharge and so on. So the goals of the programme nationally, which align broadly to ours, are reduced length of stay and bed days lost. And I think that "and bed days lost" is a really important part of that. Decrease long-term care costs by decreasing demand and acuity, so it isn't just about the flow out of the hospital, and increase the number of people receiving rehab and recovery services after an acute admission, and we would add "and before", so the admission avoidance or anticipatory care piece. And the 3 things they're particularly looking at are commissioning of recovery services and how that's done collectively. National common and professional performance standards, I think interestingly including a 1-day standard from no longer meeting, no reason to reside. So I think that's where they're getting into. It's not just the cut-off of the day. There's something about how long that then drags on. And a single data architecture and the collection around that. So that's the sort of 3 big things they want to test. In terms of, we're getting some support, not a huge amount of support, but some support through colleagues, but also the opportunity, I suppose really not just on behalf of Leeds, but on behalf of West Yorkshire as well, to influence that policy and that model. So we'll certainly engage with colleagues around that. The Prime Minister's visit, as these are often announced quite short notice, what was really good about it, 2 things I think. One is we went to a non-bed-based intermediate care setting. That came as a bit of a shock to, I think, to the understanding of what this was about, but was really powerful and really good because we met an integrated team of local authority and LCH staff working together out of a building that included a GP practice as well. So that felt really positive in terms of integration. And then we were also able to really communicate that, talk less about discharge and talk more about system flow, because that gives us more opportunity to address some of that anticipatory work at the same time, and they needed to be considered together.
Thanks, Tim. So it's good to see that we can influence through that front runner programme, and we've also made some good progress on the Leeds hub that we briefed the board on previously, where we're working closely with the Department for Health and Social Care and other institutions on workforce, some policy developments and innovation. And again, that allows us to think about some of the innovation piece. We were successful in getting recognised at the APNA Awards, which is a South Asian programme, on Friday last week for our work on equality, diversity and inclusion. And congratulations to Pam Bhupal and Rakaya Mir for their work and their recognition at those awards. The final thing I probably want Rachel maybe to say something about is there's been a lot of reporting in the media about excess deaths and what's been happening over the last year and over the last period. And it'd be good to get a public health perspective on what we know and what we don't know.
Yeah, no problem. Thank you, Rob. Coincidentally, we just had our monthly call with the Chief Medical Officer today, so it's quite timely. Generally speaking, the sort of academics, ONS and OHID are all looking at this, as you would imagine. They view it as very multifactorial. It's very, very difficult to pinpoint what the causes are. Some of it is directly COVID, as you would expect. Some of it is indirectly COVID in terms of particularly that period after an infection where you're more at risk of some of those cardiac events, etc. There's definitely a potential around secondary prevention and some of the opportunities that were missed during the pandemic that have obviously exacerbated some types of long-term conditions. Behaviour changes is obviously being key because a lot of people did change their behaviour, sometimes positively, sometimes negatively, and obviously we're picking up some of those more negative behavioural changes. Clearly there'll be an element of this which is about system problems, but in reality I think it will be a while before we can understand exactly what the proportions are between those different things. So it's not unfortunately a picture that we can easily articulate, but I suspect it will come to the fore in the future, and I don't think the COVID and post-pandemic impacts were ever not expected given what people were expected to do during that time.
Thanks, Rachel. So I think just in summary then, for the board, I think we have to always pay attention to the context that we're in. And it's one where there's a lot of contention around the impact of the pandemic, cost of living and other issues on the health of the population. It's one where there's active conversations about elements of the system that we operate in and some formal guidance out around what we should plan for and how we should be working through the operating model. And it's one where we, I think, have worked incredibly well to deal with all the pressures in front of us. And where we now have to set a course for the future with the planning guidance and the money available that's going to deliver a credible set of plans that all partners can get behind and people and staff can feel hopeful about, because we have to deal in some hope, I think, for the future. Credible hope, and that's why when I wrote to all staff thanking them, I also said things are still going to be difficult, because they are. So happy to take any questions or to use this as context to the board conversation.
Great. Thank you very much. Becky?
Just a brief one on the ONS data. Thanks, Rachel. Obviously, the different rationales or reasons for people for excess deaths requires different service responses. And whilst we could wait a long time for the data and the data could be quite contested, we could put our best minds to it. So I think for me it would be knowing how big is that issue for us in West Yorkshire versus nationally. I'm always aware of the London skew. Secondly is that I was at a very interesting seminar by COVID respiratory docs talking about the impact on heart disease of COVID, which is the same as if the whole population took up smoking. So there are some very long-term implications. But I think if we could get some of our best minds around that and we could segment it and say how big a problem is it, in what domains, and then what might that mean for us in terms of service design, I think that would be helpful. But at the moment, I don't think I understand how big the issue is here, nor where should we be collectively focusing our effort. Thank you.
I think it's a good point, Becky, and I think we genuinely benefit from having Rachel, Kev Smith, Tony and others' inputs into the work that we do. We should make sure that we pick up all of those issues as we look at the planning and challenge, I think, quite hard from the places where the joint strategic needs assessments are updated consistently through to the West Yorkshire perspective on whether we believe we're addressing the problems we now face post-pandemic and what the evidence looks like.
Okay, so I think I'd invite place leads to explore that within place committees, and then also Majid and Becky through the quality committee and working with James and Bev as medical director and director of nursing. We can take that system and place perspective. Tim, did you want to come back?
Yeah, I mean, yeah, we should take that challenge. I know colleagues, I've got a report here I'm just reading through from colleagues in the public health team in Leeds around where they see some of that and how it plays out in terms of Leeds. So I think it is really important that we do. And it is one of those things that we can come together around. It's a really clear piece of work once we can start to tease out locally what some of those issues might be. So I think it's potentially quite a unifying and integrating factor and goal. So yeah, really support that.
Great, okay. And also noting the value of our public health colleagues, both at system and at place level as well, and working with us on that. Okay, thank you. Hannah, do you want to come in?
Yeah, I suppose just to highlight in terms of Leeds being the front runner around integration. Oh, sorry, can you hear it? Okay, sorry. And I'm sure we'll do it in Leeds because that's the way that we do it, but it's keeping people's experiences outcomes central to that. It's not just about achieving the targets that NHS England have set around that. It's making sure that it doesn't impact adversely on people and family and carers as well. So just keeping that central.
And the role of public health with Health Watch, with colleagues from the voluntary sector and bringing that in as well, linked to our involvement framework. Okay, James.
Yep, so I'm James Thomas, I'm Medical Director. So just picking up on your points, Becky, I think really important we understand, as Rob has said and Rachel, in terms of what does that mean for us here and in places. I suppose from being on recent meetings and from that, I suppose that summary that Rachel's given there, secondary prevention is going to be a significant ask of us, given what we've seen and the impact we've seen just on a short period of time with COVID and the effects that's had on delivering care. I also think it's also about making sure that people don't have just one condition, they have multiple conditions, so we're not just looking at secondary prevention for cardiovascular, but that people have respiratory cardiovascular, so it's about looking at that and how we personalise that as well, but big emphasis on the secondary prevention.
Thank you. So we'll make sure that we thread that back into our board meeting in March through the quality committee that's happening. Oh. Hearing myself in stereo, our quality committee that happens next month and through the next place committees as well. Also, in complementing that piece of work, just a reminder to us all of the Integrated Care Partnership meeting at the beginning of December, where we signed off and agreed to support as an overall partnership the Cost of Living Response Action Plan, which has a number of different elements to it. And if anyone's watching the live stream or online afterwards, you can find that under our Integrated Care Partnership section on our website. But it's just a reminder to all colleagues as well, make sure that we're keeping that action plan alive. Again, hearing myself in stereo. Thank you, Rob. Does anyone else have any questions on Rob's report? No? Okay. Thank you. And thanks for raising that, Becky. I think we just continue that oversight of that issue and the scrutiny of it. Okay. So we'll move on now to item 13, which is our board assurance framework. So Laura, over to you.
Thank you. So members of the board will recall that we have spent quite a bit of time in development mode and also in previous meetings updating on the progress in developing our board assurance framework, or our BAF as it's better known. The BAF is built on the ICS mission, it's built on the ICB priorities with the risks to achieving those articulated within the document, and each has been assessed against our agreed risk appetite. At the last meeting, I explained that we were setting up a task and finish group, which is being made up of a number of board members alongside partners, including our auditors, to support the continued development of the BAF. The group has overseen the linking of each risk to a lead director. Each risk has also been linked to either a lead committee or the board, which will ensure that we have ownership of those risks going forward. And each of the lead directors has populated the ICB core controls and assurances and started to prepare to link with places. So this marks the conclusion of phase 1 of populating the BAF, and following today's board and any feedback from yourselves, we will move to phase 2, which will see each place populating their section. The task and finish group are due to meet again in later this month to support this next step and to reflect on any feedback from the board today. And we'll then bring that back to our March meeting. I'll pause there, as that's just by way of introduction. I'm conscious that members of the task and finish group around the board might want to comment at that point.
Great. Thank you very much. I suppose this is an example of taking our governance handbook. I was going to say our homework. It has felt like homework as well. Taking the Integrated Care Board Model Constitution and the best practice that we all bring in bringing that together. I particularly want to thank colleagues at Audit Yorkshire who've joined all our task and finish groups and been really honest and challenging with us. I think that's helpful to us. And Andrew Chang, who's the audit chair of Yorkshire Ambulance Service, in effect, been our co-opted member alongside executives and non-executives here. So Jenny, I was going to pick on you there as audit chair, because you've been part of these task and finish group sessions. How do you feel the progress has gone?
Yeah, thanks, Cathy, and thanks, Laura. I think the discussions we've had have been really useful, and I think hopefully colleagues find that the documentation that's come forward today, it's the first time I've seen the populated versions of templates. So, well, I did get a preview last week, but so I think it's encouraging. I think obviously further work to be done, but I think the exec team have done a really great job actually in terms of getting it this far. I do think as we move forward with it, the more we can focus on, particularly obviously where we are out of target, focusing on the further mitigating actions and focus the qualitative discussion and input into those sections through the subcommittees and those who are responsible for these different strategic risks. I think that's really critical. I think at the moment we've kind of captured a sort of where we are today on these. I think we absolutely, you know, there are obviously some significant areas where we're not where we would like to be, and the sort of, you know, tangible real actions that we're going to do that over time is going to get us back to target, I think is really important, and more action focused, I guess, in the narrative there. I'd be looking for a bit more so than, you know, we'll have an audit in this area, or, you know, some of the examples that kind of cover the basics, but I think it clearly highlights where we've got some further challenge. But I think really good progress from hopefully what the board have seen previously. Thanks.
Okay, thank you. Becky, I'll come to you in a moment. I just think if you can remember back till June when we were in Leeds again, actually, Leeds again today, when we talked about how we wanted to connect strategic risk management between the Integrated Care Board, which didn't even exist in a statutory footing at that point, into places. This document is aiming to do that. I suppose it's our responsibility then to make sure it stays alive and it's relevant. And I think that's very helpful, Jane, about where we're looking at gaps, further mitigation. I always look at the gap section in these kind of documents and where we're going to next. Okay, thank you. Becky, do you want to come in?
Just one comment on the BAF. Thank you. I mean, it's just really good to see this all together. It's always been really hard to get a picture when you come in just on a temporary amount of time a week, and this does really help. But can I just remind us about what we mean by rationing? So it's on page 192 of our 454 pages. And it says no indication that services are being rationed or will need to be rationed. And just that might not be the public's experience. So back to our September meeting with our children and young people and their families, they felt waiting was rationing, or they felt that not being able to get anything for over a very significant period of time where they're having to sort themselves was rationing. So it might not be not commissioning it, but it might not mean the experiences of things being rationed or not. So that might mean that in our key controls or mitigatings could be some work with the People's Panel.
Rob, do you want to come in on that?
Yeah, I think it's an important thing for us to work through, because I do think that there's a difference between waiting and rationing, and in terms of the intention and the conscious decisions that are being taken. So there are a number of things where people are being forced to wait longer than we would like because of supply. Even if we've commissioned the service, just not delivering the targets, it's not because we've intentionally decided to make people wait. There have been times in my career in the past, I'm sure others looking around the age of some of the people around the table, where we have decided that we could make people wait a little bit longer to save some money and still hit national targets, which I think is a form of rationing. But at this point, I think we should be thinking about if we believe that it's better to make people wait because it's the only control we have to manage costs, and at the same time it will preserve quality, that's a conscious decision to ration, I think. I'm not sure we've ever been in that position yet is around this board, but if we do get there, we should be very, very clear about it. I think you're right.
Thank you, Becky. And I know you're on the Finance Committee and Performance Committee as well as Quality, so I think that's a thread for you to continue on. Okay. Would anyone else like to respond? We're moving on more to the content in the Board Assurance Framework. Does anyone have any queries at all in relation to it? Rob? I won't mind a board perspective on the content. So like others, I'm really grateful that we've managed to co-produce and create this set of strategic risks in the BAF. And conscious that we've got 2 which are currently scoring 20, and we have 1 where our target score is 16. And are we happy that our target score for reducing inequalities is 16, which means it's almost inevitable and it has quite a significant impact? Are we happy that we've got 2 which currently are scoring 20, which in terms of strategic risks, the likelihood that we'll bust our money and the likelihood that we won't be able to do anything about inequalities. I think that those are things which probably warrant further conversations, either later in the agenda on the money
or as part of our planning conversation.
It's a challenge out to us all, and this is what this board assurance framework is aiming to do for us, yes. I don't know if anyone wants to respond, place leads, executive colleagues. Rachel.
Thank you for that, and I'm very conscious that it's really difficult to get something like this at a strategic level that covers everything. And I suppose in relation to Rob's challenge around that first one, I guess for me it's almost like, what does good look like in relation to reducing inequality? Because actually we do know that things like poverty and other elements are probably, we are probably as an integrated care board not going to be able to impact on that in a way that would. So I suppose what we don't want to do is have something in here that we will never potentially change, because it is always going to be outside of our gift. And I guess it's in the next iteration of this board assurance framework, it's almost like, what are the bits that we are in control of, or that we can influence in a way that will at least move us into that direction, accepting that there are things that will always take precedent in terms of particularly the wider determinants of health and the inequalities that are associated with that. So I guess for me it's almost like, and I know this is an easy answer, isn't it, to change your ambition, but actually, if you've always got something that you will never change because of how it's described, let's try and focus on the things that we can make a difference on, would be my take.
Great. Thank you, Rachel. And I think those discussions have come out in our integrated care partnership, where we've been talking about what our role is in alleviating poverty, which is a whole new area for the NHS, I think, proactively to be working as well. And I'm pleased we have got this action plan around the cost of living crisis, for example. So I think that's a challenge back to you, Rob, and us all. Karen, do you want to come in? Would you introduce yourself, Karen?
Yeah, of course. I'm Karen Jackson. I'm the Chief Exec at Locala, and I'm here as the Sector Lead for Community Services. I think this is incredibly helpful and really powerful. I think there's going to be some decisions that we need to make through this planning round that are interrelated. So if you think about some of the decisions we might choose to make about health inequalities, they might impact differently on the resource envelope, and that threads right the way through this. So actually, these are really helpful to hold in our minds whilst we're making those prioritised decisions as we go through the planning process. So I hear what you say, Rachel, but actually I find this quite powerful to see it like that, and to be able to flex this as we make those decisions and see the impact. I think that's where the value is, so that we can really understand, so what then? Thank you.
Okay, great, which is then the benefit of having this document connected to places as well. Becky, and I think then we've got Jonathan and Ian. Becky.
Yeah, I absolutely support that. And Rachel, I think what was really interesting about what Tim was talking about around integrated care and taking the Prime Minister out into a community is that whilst we can't perhaps solve poverty, we can tailor our services to better meet people who are poor, which is basically nearer where they are. And we've been talking about that many times. So keeping this in mind means that we think about how we design services, particularly around access. We were fantastic in the vaccine programme at getting our stuff out to people, and we need to continue to be fantastic at doing that. And I think some of the opportunities around integrated care means we will do it. So it's good to have it here. I think it's really important, Rob.
Great. Thank you, Becky. And for some of us, well, for those of us who joined the engagement session this morning, some of you had the opportunity to talk to some colleagues from community pharmacy who were talking just about that, about taking services out into communities. Jonathan, then Ian.
Thanks, Chair. So it's really in relation to strategic risk 3.2, which is around managing the money. So probably three things really just to sort of comment on. I guess the first is the process by which these were derived, which was through executive director lead and drafting, which was me in this case. So the lead committee will be the Finance, Investment and Performance Committee, who haven't yet had a chance to sort of almost like moderate that. So they may well differ with this view, but my professional assessment back in December was, I think this warrants a risk of 20 based on the likelihood and potential impact. So I suppose that's the first thing. The second thing, this was very, well, to an extent this is point in time, so pre-planning guidance, the risks I think were around that area. I think today, I still think the risks are around that area until we've got some better developed plans coming through, to be perfectly honest. So I think we can keep it under review, but I do feel as though that is an appropriate risk to have at this time across the ICB and the ICS.
Okay, thank you very much. And for openness and to record in the minutes, we did have a board meeting in a private setting this morning because of the sensitivities around the issues we were discussing. But one of the things we agreed is that a Finance, Performance and Investment Committee would be looking at our forecasting and planning ahead. We would have a group of people from the board working on that to make sure that we're agile and flexible and responsible in that, and that we'd have a board development session in February and looking at our planning for the new financial year. And our next board meeting in private would also look at that as well back in March. So just that's helpful for Stacey for the minutes, but it also in terms of being very open. Ian, over to you.
Yeah, thanks. I think Becky's covered my point to an extent, which is, I mean, we thought quite hard about the wording in risk 1, and the reason why it's so high and the reason why it only comes down to 16 is because those external factors that we reference are present and they're real and they will continue, I guess. I think Becky's response is exactly where I was coming from with this, which is, are we doing as much as we can as a health and care partnership to mitigate it through the work that we're doing and through the way that we're influencing upwards, which is why we've got 20 and 16. I think the work that we're doing around the joint forward plans over the next 6 months will be really important in terms of providing the assurances around those risks.
Great. Thank you. Jane, did you want to come in? And then AC.
Yeah, sorry, I was going to come back on Jonathan's comments on 3.2. So I guess that's an example where I would hope that as we sort of further develop it, and I do agree with his judgment that the scoring feels about right, but I do hope that, you know, from a mitigating action perspective, you know, it has to move beyond having a framework and fora where we discuss on something like this to, you know, to get us back to that target score, which I, you know, suspect Finance Performance Committee would endorse. That means by the end of March we need to have plans that manage within what we know are going to be sort of pressured financial envelopes, etc. So I hope that we'll see significant movement, but I don't underestimate the challenge that that's going to create for many organisations represented here. I was just to also think about Ian's comment. I think it will be interesting to see how that one gets reviewed, because that's your 1.1, was it, is owned by the board. And where's the fora that we're going to review the scoring of that, rather than it being a single executive's view on that? So I think, and it is such a significant one, I think, to all of us, and balances a bit against the financial resources, etc. So I think we need to think how we manage and ensure we have those conversations that balance between some of these risks, and that one is a critical one.
Okay, so it's an invitation from Audit Chair to make sure that we have plans in place that we're bringing to our March meeting. Jane, thank you for that. So we've got AC, Tom, and then Majid. AC, over to you.
Thanks, Kathy. Going back to sort of Rob's initial observation, is 16 ambitious enough? And in the context of the discussion, should we review it with the perspective of what we can do actually, and that make it meaningfully ambitious for us, which is within our goal, because 16 doesn't look ambitious. It looks like we are going to fail on that target, which is one of our key sort of ambitions of reducing inequalities. So perhaps while reviewing it in terms of how we can narrow the gaps based on how we provide services, and hence change that context of understanding, and then having a clarity of what the ICB, ICS could do within that remit, and what's in the remit of local authorities and others.
Okay, thank you. And places as well, and to come through. Okay, thank you for that. Tom, then Majid, and then we'll move on to the next item.
Thank you, Chair. Just to respond directly to Rob's question, I don't think we're happy as a board, are we, about the inequalities situation, but I think the way it's worded is quite helpful, in the sense that it does make clear that this is not being delivered due to the impact of the wider economic and social factors. I wonder whether it might be that there's something else in the other elements cover it, but and I think our prediction, the target score and where it's landing, is one that we were sort of anticipating it. I think the other one is slightly different for me, because in terms of the resources, and I don't know whether this is wording which is given to us or whether we can affect the wording of it, but I don't quite like the wording about we're breaching our statutory duties within the resource envelope available by not delivering efficiency or controlling cost. I feel a better description would be something that refers to the resource envelope allocated to us, because I'm not sure, again, if I was to give a view that's maybe slightly more subjective than you could, as someone in the wider system, I think we'll have been doing all that we can to address that issue, but we probably will breach it. I guess the question for me in governance terms is that the distance between our target and where we're coming out on that one is bigger. So is there something about us getting better at the start of the year at anticipating? And then the final thing I would say, having done this over the years, is that I always think these processes, the processes are there for a reason, and there's a sort of level of assurance that we've got to do, which is absolutely right. But there's also a hint of sort of reality about how useful this sort of thing can be, because a pandemic probably was on there somewhere originally on all our plans, but it probably wasn't right at the front of our minds. So, yeah, I think using this in a really effective way is what I'd encourage us to do. There's an awful lot on here. We've got risk register later. There's a limit to what you can do, but it's about using it in an effective way as a board.
Okay, thank you, Tom. So it's about pragmatism, but complementing Jane's remarks on action as well. Majid, and then we'll finish up.
Thanks. Just building on what AC said. So I don't think we can be happy with 16 as a mark for inequalities, because the inequalities is split into 3 sections: the access, experience and outcomes. So with access and experience, absolutely that should be a lot lower. Okay, outcomes, we've got other factors that are outside of our control, so maybe if we split that into 3: access, experience and outcomes. And also I think we have, as part of our strategic aims, to support broader social and economic development, and that should also help address some of this. I think that should be in there too, to help reduce that further.
Okay, thank you. Which comes back to earlier discussions we had on workforce about looking at it more broadly, looking at housing, for example, and support, and not only for our staff but also our communities. Okay, thank you, Rob, for the challenge. Do you want to sort of have the last word on that, as it were?
Yeah, I just think that's a really helpful bit of conversation, because picking up Tom's point, what it says to me is that as we've been developing this, we've had the economic incident that took place late last year, which has led to a cost of living crisis, which is impacting on people's health at a level which is impacting on our ability to deal with health inequalities. And we as a board have to pay much more attention to the money, because the actual financial position we will find ourselves in next year, as we talked this morning, is severe, the degree of financial challenge. So we have to get ahead of that. So that focus on the money and efficiency and allocative efficiency is helpful, as is the constant conversation about what are we doing that's going to improve the position on health inequalities.
Okay, thank you very much. Laura, just what happens next with the Board Assurance Framework?
Thank you, sir. I've been busily jotting down the feedback, which will be really useful. It will go. We're due to have a conversation with the executive management team next week, and the Task and Finish group will also be meeting in the next couple of weeks. We will reflect on the feedback and help to continue to develop the document. We will then be populating the place element, and you will see it back in March.
Okay, great. And we continue to look at best practice in other parts. We continue to look across our North region, as I mentioned earlier today. We noticed that Lancashire and Cumbria Integrated Care Board have just developed their board assurance framework, which is a good one to look at, but they haven't incorporated places yet. So I know that's a great extension that we've got in connecting our work together across 5 places. Okay, thank you, Laura, and thanks to everyone involved in that. Okay, we'll move on to the Integrated Performance Dashboard. So Anthony, what would you like to highlight with us? And then colleagues, happy to take questions and hear responses. Anthony.
Thanks, Chair. So you have the latest performance dashboard. Just to remind members of the board, this is based on the indicators of the NHS oversight framework. So it's not a comprehensive view of all of the ICB or the partnerships activities. It's also compiled based on publicly available data. So it's necessarily slightly out of date in the sense that it reflects, depending on the indicator, typically sort of September, October, November position. So therefore, of course, it does not reflect the recent pressures we've seen right across urgent and emergency care, primary care, other sectors across the Christmas and New Year period. So just to acknowledge that, if you like, the timing of the data that's reflected in the report. I'm not going to go through the detail of it. I'll obviously pick up any questions colleagues have. What I would just point to, though, in the cover paper, which provides a bit of more up-to-date context on the current position, if I can just point to section 3 of that report, which talks about planned care and in particular the work of the Citizens Panel. We've included that update because of the discussion we had at the last board meeting around how we could reflect the experience of people waiting for elective care for planned operations and procedures. So the paper there gives a bit of an update from the work of that Citizens Panel that's been working through the last year to support patients as they wait for routine care. Just to acknowledge as well that I think most meetings we have a discussion about this. There's always a number of things that I think we collectively think would be useful to add to the report. And Cathy, very helpfully, you've suggested we form a task and finish group to involve members of this board, which will help us prioritise, if you like, the further development of the report in a way which will enable us to try and address as many concerns and priorities as we can in it, if like a planned piece of development work. So thanks for proposing that. I think it's a really helpful offer, and we'll take that work forward after this meeting. So before I open it up perhaps to questions, Cathy, if I can just hand over to Jonathan Webb just to ask if Jonathan wants to say anything about the financial elements of the report.
Sure. Jonathan, over to you.
Thank you. Just one issue to pick up quickly for advising the board, really. So, as Anthony said, this is about the finance indicators that are included within the oversight framework. The only one indicator I want to draw the board's attention to is our in-year performance and our forecast for this year. So, despite next year being challenging, as we've just described, we are heading towards achieving our plan as a system and across our 11 statutory organisations across the ICS in 22-23. Probably worthwhile the board noting that comes on the back of an aim to both deliver our system break-even position, but also to ensure that every organisation in West Yorkshire delivers its plan in full. And to get to that position, we have invoked our financial risk management arrangements as set out in the framework, which talks about risk being managed in organisation, place, and then the system. So I suppose that's all I wanted to really update on today. Thank you.
Okay. Does anyone have any questions in relation to the integrated performance report? Becky, then Hannah.
Thanks, Anthony. I remain disappointed that primary care is seen to be such a secondary citizen on the performance report, in that we're still persistently reporting on acute care. And despite, Anthony, I know you're saying this is what's required to us from NHS England, but NHS England does end up then still publishing stuff on primary care, somewhat out with this. It doesn't make sense to me. So I do think we need some primary care metrics that make sense. Obviously, the GPAD data doesn't. Patient satisfaction really does, actually, and it's a really good indicator of where our practices are. So there are some things that I think our primary care colleagues would get behind that are readily available and should be in here. I welcome the idea that we might integrate our metrics a little bit more so that we've got not just this, but something that reflects our strategy and reflects the dashboard. So we have a set of metrics that make sense for us as a whole, not to overburden ourselves, but at least to create some balance in the whole. And then I think, secondly, Anthony, I've asked, as you know, repeatedly around not percentages, but real people. There's a little bit more of that in this, which is good, but we still seem to always, around our mental health services, talk about percentages and not real people, and around our physical services, real people and not percentages. So I really welcome a shift in that balance. Thank you.
Okay, thank you, Becky. And I know you've volunteered to come and join the Task and Finish group, so I think you'll be a really important critical friend to this. Anthony, do you want to just respond on that? I think this is a work in progress, isn't it? But I think Becky's got some fair challenges.
Yeah, very much so. And thanks, Becky. And yeah, I think the Task and Finish group can very usefully look at what, for example, from the scope of primary care data, we can include in the report. So let's prioritise that. And yes, on the point about including absolute numbers as well as percentages, apologies, we haven't been able to build that into today's report. I've circulated an addendum to the chair and a number of colleagues with some of those numbers in, and we will build them into the report in future. And obviously, I'm happy to answer any questions on specifics that people want to pick up in terms of numbers that arise from that.
Great. I think we've got Hannah, then Karen, and then Tim.
Yeah, it actually builds on what Becky was saying, but and I know when Becky and I introduced the paper at the beginning of the journey of the ICB around making sure that people's voices and experiences, almost in that sort of co-leadership model, and I know we said we want to do some work with you around the performance dashboard, but I suppose just the conversation, and again it builds on the conversation we had earlier about how the involvement sessions that we have in ICB and how those relate to the direction of travel and the work that we do as an ICB, but things like the variation in access around GPs, that was a key theme that came out of the first insight session. We've already talked about access to NHS dentistry as well, so I suppose it's just getting the things that are really important, timely access to mental health support, all the things that we know are important to people and how they relate to that. And if I may, Cathy, just one point, I probably should have said it, I haven't quite got my head around the BAF and this document, but also just on the inequalities bit, we've done a lot of work around actually what can health and care organisations do to better meet the needs of people to address health inequalities, like good access to GPs, like good front of house, like adhering to the accessible information standard, like making sure that the targets around elective care have, understand the data and who's accessing that care. Digital, how is that excluding people, how is that not? So there's some very specific things I think we can do around inequalities, and I should have shared that earlier, sorry.
Can you bring it into place as well as to this group? Thank you, and I think then it comes back to what I know our non-exec colleagues, one of the points you made about variations in access comes back to the point that the exec team made around making sure we're always getting those four purposes of the integrated care system, always about variations in care and access. Okay, thank you. Karen, then Tim, then Richard.
Thank you. And this comes with an offer, Anthony, so I'm not just chucking things out. I think what's interesting in here, and it plays with what Rob sometimes says about what you measure, you do. And I wonder whether we need to think about the whole of the flow system and how we measure that and monitor that. So it's not just about primary care, though that's important. It's about all of those providers and services that support. And I wonder whether we could think about how we measure outcome. So if I think about some of the things around the 200 million that's coming for discharge, we need to think about not just measuring the input, i.e. how many beds have we bought and how many people have been through them or what have you. It's the outcome for those people, because what we don't want is people placed in those beds who don't get rehab and support and actually go back around the system. So I wonder whether there's something we could think through there, and I'm happy to be engaged and involved with the discharge team as well, please. Thank you.
Thanks, Karen. And perhaps that's a style in all our reporting. I'm just, how we look at the outputs and the outcomes. I'm also interested in the sort of case studies of integrated care, that point as a more mature and established system, how we make the case for integrated care across our system and outside of it as well. Okay, thank you. Tim, Richard, Jane.
Thank you. I was going to mention the outcome one, but that's been done.
Sorry.
No, it's good. It's good. I think this is going to sound like I disagree with Becky, but I don't. I think what we need is numbers and percentages, because there's an example in the day surgery, just as one, where there's lots of numbers and Leeds is in red, and it's like, well, of course it's got the highest numbers because it's the biggest trust. And I think there's something about just bearing in mind those kinds of issues in the way this is presented. If I was a patient and didn't understand that context, I'd think, oh, I don't know, I want to go to Leeds. But actually, that isn't what that means. So I think there's something about how we present the data that still needs a bit of work. And also to bear in mind, you know, Leeds in a comparison as a tertiary centre is a really different beast than some of the other ones on here. So I don't know how we do it, I'll be honest, but I'm happy to help think that through. But I think that was just the sort of basic point I wanted to make. And then the third one was just around the 31 indicators in the planning guidance, and whether we see that as the primary piece at the core of everything, or we don't. And I think there's quite an important decision for us as a board to make around that going forward. Otherwise, we could have hundreds. We're going to be managed, monitored on the 31. So where that plays into this, I think, is a really important question.
Okay, thanks, Tim. I think you might have just volunteered yourself for the task and finish group there as well. Okay, thank you. Richard, then Jane.
Yes, it was just following on from Becky and Tim's point. In just one example is the IAPT waited less than 6 weeks, so we've obviously got a drop, you know, in the performance there. What would be really interesting to know is how many thousands of people does that relate to? You know, is this a major issue for our system? I think it is, but you know, actually just getting those figures, I think, would be helpful to know. Just on the primary care data, I think we do need to be very careful what we use, because some of it is not really very helpful at all and can give very skewed information. The GP access surveys are produced once a year, so I think that's something that can be helpful. Just going back to the conversation earlier in the meeting and this morning around workforce, actually, if we were to say, including and expanding our workforce is a good indicator of quality of care, assuming that the two link together, and I think they probably do, then actually including some of the a very small key number of metrics around our workforce within our report here, I think would be really helpful, so that we can actually keep a track of how many dentists we've got, how many GPs we've got, you know, how many nurses in particular settings we've got, whatever it might be. And I think that would be quite a useful indicator as well as to how improving in terms of accessibility we were, because if we've got more people, we're offering more services.
Thank you. And Jane.
Yeah, thanks, Kathy. It was just a question actually around section 4 in the paper, particularly around the adult social care discharge fund and the allocation. And I guess I was just interested, particularly having earlier discussions around the sort of challenges in that area, how effectively we felt that we have been able to deploy and utilise the resources that we have been allocated to deliver in terms of, you know, what we were targeting to do with the allocation, whether we've managed to do that or not.
Thanks, Jane. I think, Karen, would you respond? And Tom, would you come back in as well? Thanks.
Yeah, so it's work in progress. We're taking a presentation to the meeting tomorrow, tactical meeting. It's not been allocated. You almost have to do the work and then tell what you've done in order to get that back. The point I was making there about the dashboard, the daily reporting, is all about inputs, not outcomes, and so that's a conversation we're in. So there is a plan, we're just at the beginning of it, Jane, and we'll come back to you about that.
Okay, Tom.
I think this is a good base, and I really encourage the Task and Finish group to take on board some of the comments. I do think the one about the scale and the population of different parts of the region is really important, and to use pictures maybe to get that across sometimes. I also think trends are really important, and you know, we're doing a lot of work on the economic side trying to look back to 2019 and track where we were relative to that, and I know anyone who speaks on behalf of primary care in the last you know, a few months and the last year who really knows about it and works in it will talk about, you know, the extra numbers of people that they're dealing with compared to previously. So yeah, I just really encourage a bit of license for the team to use pictures more to get across the differences between the different parts of the system and the different parts of the region, because they really do drive how we work and how we can use analysis like that for better decision making. And yeah, it's just a fundamental part of what we do, and not everyone reacts to data in the tradition, looking at a traditional table. Some people like pictures more, and for the general public that would be good as well.
Great, thank you. It's something our non-exec team have been asking as well, how we make parts of our data very accessible to members of the public. So thank you. Okay, I think we've got a lot of information there, Anthony, to take away, some practical things around specific services or areas, or places, should I say, as well as how we take these things forward. Rob?
Yeah, I just wanted to get on the board's radar. I think it was mentioned in passing, but we need to really make a decision about it. All the data you got in front of you is published data, which means it's out of date for decision making. And what we want to do as a board, the board's here for assurance results to make decisions and choices based on the plan and the strategy that we've created. So we're going to have to find a way of getting more timely data in front of us. So Mel and Tom and Tim and others will be sitting in organisations where they do that. You don't have to wait for NHS England to publish the data to look at it, and they publish it in their board reports and they get on with things. But because of the way that we're structured and the way that the data works, we're not allowed to yet. So I think the first thing is the board should really be lobbying to change that so that we don't have to wait. It might take some time, effort and energy to do it. I think the second is just to come back to, we want this so we can oversee the delivery of our strategy, and the choice we then have to make is which priorities are we measuring against our plans, which targets are we monitoring, is it the 31 plus, and what's in the dashboard, and then how's it presented, as Tom says. I think we talk about this a lot. Why don't we say we're going to get this resolved in line with the planning? So once we sign the plan off, we must have a dashboard that works, which is operated at place and West Yorkshire level, that meets our needs as a board. So why do we set that time scale? That'll be July, I guess.
Yep. Okay, great. Thank you. Everyone in agreement? And there's a lobbying point there as well. I think there's a few throughout the meeting today in our discussions which we can then draw out. Okay, thank you. So I think, Anthony, you have myself and Becky at least to start taking this forward. AC has volunteered as well, and Karen has as well. And if anyone else is interested in Majid, you're going to have a whole non-exec team by the end of this to work with you. And I think that's a really helpful guide there and a framework. And I think, Anthony, you felt July was a possible in taking it forward.
Yeah. So some really helpful offers. Really appreciate that.
Okay, great. And this is what we're continuing to do as a board, aren't we? We're taking the information and we're working through the format so it's useful to us at the same time as looking at what it's telling us to have that debate and discussion. Okay, and there's continuing lobbying points. Okay, right. Next item we have on our agenda is our corporate risk register. So this is sort of live risks in our system as opposed to our board assurance framework, which is around strategic risks. Laura.
There we go, sorry. It was saying busy at me, I'm not sure what that meant. You very much know what I was just going to say as my introductory comment, Cathy. So this report is very much designed to complement the earlier report on the board assurance framework. It's focused on the other parts of our integrated risk management frameworks, so very much focused on current risk. Today marks the end of the third risk cycle of the ICB, and within your report you have details of the West Yorkshire corporate risks. You have individual place risks that are scoring 15 or above, so that means that they are high level risks, and you also have an appendix that sets out risks that are common to more than one place to draw those to your attention. The risks have been reviewed en route to board by the Quality Committee and the Finance, Investment and Performance Committee. In terms of key messages I just wanted to pull out today, draw your attention to the 7 new corporate risks that are within the report. It's quite a large number, but just to give you some assurance, that number can largely be attributed to the fact that we did identify new ones during the last risk cycle. So the primary care delegation and industrial action risks are new. And we also had a number of risks that we chose to move from the place risk registers to the corporate risk register this cycle. Particularly draw your attention to the highest level risks we have, which are set out at paragraph 3.7 of the report. And a couple of final points around the way that the report is designed. So we've developed the report this time to not only share the score of each of the risks, but to also give you a breakdown of the impact on likelihood so that you can get a feel for how those risk scores are made up, and arrows to show whether the score is static or whether it's increasing, decreasing or new, which will hopefully help you with navigating and also focus attention on those risks. And the final point on the risk on a page report, which is designed to give you an at-a-glance overview really of our risk profile as an organisation, and also to give you some trend data. We are still a very new organisation, and so you will see, for example, that the average score is coming down. That is likely as a result of work to ensure consistent scoring across the risk register, and also because we're including a fairly large number of new risks during the first 3 cycles. As we move further on and we get into further risk cycles, the risk on a page report should become more and more useful. It will help to give you the trend data that you need as a board, but just a note of caution at this stage as we're only in the 3rd risk cycle. Those are the main things I was going to highlight, Cathy. I'll pause there.
Okay, great. Now it's on. Okay, happy to take questions. I just wanted to sort of tee up, Kim, whether you want to come in on looking at sustainability of the voluntary and community sector, and Bev, whether you want to talk about maternity services. It's something from a theme from and an area of oversight from last time. But are there any other comments, queries at all in terms of that? Becky? And then AC and then Jane.
Thank you, Cathy. So I could see we're not getting any increasing risk, but it sort of doesn't feel like that. So when I look at the place-based reports, obviously there is obviously a lot more language around safety and harm. And that's our experience, that's our public's experience, that's our staff's experience. And it doesn't, so are we admiring the problem here? Was my question. How we, if we're not careful, it sort of becomes a number and we get a bit immune to it. And I'm very cognizant of the language in the place-based reports, and then, so what discussion do we really need about this now?
Okay, and perhaps we can invite the place leads. I don't know, Rob, do you want to comment? We don't want to get into a new normal, which is...
I think it's important to think about that the safety and harm thing is really important, isn't it? What were things safer or less safe on strike days? Well, we had lower demand, better handover, better clinical decision makers at the front door of ED. Things seem to work better, but there's a consequence for delays elsewhere. So, inconvenience, minor harm, maybe psychological distress for some people who are delayed. The way that we look at harm is through incident reporting, isn't it? So I do think we have to get into what kind of incident reporting are we seeing? What are the trends? Are there issues on particular days? What have we seen in terms of critical incidents with ambulance service, etc.? I don't know, Bev, if you want to say anything about the Quality Committee and what they're doing on that.
Yeah, thanks. So in terms of industrial action, I've spoken to all chief nurses who have their providers that have been involved in industrial action, and as you would expect, they've had really robust processes in place to look at whether or not there was harm on the days of the industrial action. And the risk profile, there's been no change at all in any of the providers in risk profile, and I've compiled a report actually about it, and that they've been reviewed through individual organisation governance structures, reviewed by the chief nurse and medical officer in each provider organisation. However, what I'd say is the risk to the elective recovery plans will increase as each day that we have industrial action, because the derogations as such are for life-preserving services. So they are ED, ITU, P1 activity, chemotherapy and dialysis. And the first round of the RCN industrial action, there were many more derogations than have been approved for tomorrow and the day after. And the activity is increasing, so we've already seen that there are another 2 days planned in 2 weeks' time. So that will be the risk. I know that the chief nurses and medical directors in place are reviewing the harm, patient harms on a, well, they do it on a weekly basis, but some organisations put a specific code in DATIC so they could extrapolate that information. And in addition, they've looked at the days before and the days after. The other theme that we saw was some delays in discharges on the strike days, and they were not just the RCN strike days; they were also when the ambulance action was undertaken, because again derogations. What I would say, because I think this is the opportunity, is each provider that are identified to participate in industrial action have got to fill in an action plan to mitigate the risks that they might see, and that's seen at system level, and then we have to submit that up to region. So plans are put in place, but as I've said, as activity increases and more people start to take industrial action, then the potential for harm clearly is greater. Thank you.
I think I could just come back on that, because it wasn't about industrial action. It was about, in the risk reports from place, it was about it wasn't. This is a day-to-day risk, not specifically around industrial action. It was the growth in language about harm and safety across the system on a day-to-day basis.
Yeah, I think it's a point well made, and that the arrangement still follows. So strike days are an amplification of the arrangements that take place in organisations on a daily basis. I think this week we've seen our organisations, our acute organisations across West Yorkshire, reduce their OPAL scores, and we're all grateful, but it's not good, the situation we're in. Having all our organisations at OPAL 3 is not good. It's better than being at OPAL 4, but it's not where we want to be. So I guess one of the risks is we start to normalise the situation. And what we've got to do, I think, is always try and get hold of, well, what is happening in terms of harms? Is there a lot of distress and noise in the system, or are people coming to harm, and what do the reports say? So I think that combination of tight management in organisations and the system of things on a daily basis, which is amplified or not depending upon the degree of pressure, plus good incident reporting, is essential. Now, the Quality Committee and the Place-Based Committees need to look at that in the organisations too. I don't know if Mel or Brendan or Sarah or any of the other provider chiefs want to give a sort of perspective on whether we think things are getting more difficult or whether more harm's occurring, or how we make sure we're on top of whether it is.
Thank you. And I'm happy we could sort of blend it into the Committee A reports, which you're referring to there, Becky, and Place Lead. So perhaps if we go to our Place Lead colleagues, and then Sarah and Brendan, from your sector perspective, we'd welcome hearing from you. But then I don't want to leave out coming back to you, Kim, on voluntary sector, and back to you, Bev, on maternity as well. So Mel, are you happy to go first from Bradford, and Craven, and then Neil will come to you?
Oh, thank you, Chair. And I'll be brief and just concur really with what Rob says. If you think about the period that this is reflective of, would it be a surprise, given all that we know about how it has been, that we are flagging up concerns about, at best, a drop in the quality and the standards that we are able to offer the people who use our services, and at worse, the fear that they may come to harm, and the purpose of putting them in this sort of mechanism really is to be upfront about that, and then to take the relevant, appropriate mitigating actions to try and minimise the impact of those pressures. And given that, at that particular period, we were largely in OPAL 4 as places, some areas considering declaring critical incidents because of the sheer volume of patients and the pressure that was conferring upon the system. I think it's to be expected. I've had similar conversations in my own organisation. What a difference a week makes to say, well, did we really put that risk at 25? Well, we can say that now, can't we? But at the time it was put at 25, it felt like a 25 risk. And in a way, you kind of look at it in retrospect and say, well, it obviously worked then, didn't it? Everything that we articulated that we would do to try and minimise harm, if the risk profiles are correct, has worked.
Okay, I'm just going to go, if we go round place and sector leads, but AC, Jane and Rachel I haven't forgotten. So if we go next to Neil and Calderdale, then Carol, Joe, Tim, then Brendan, and then Sarah will come over to you. I'm hopefully giving you some time to prepare as well, just to give a response. But I think it's about this pressure at this time, some people perhaps thinking this is a new normal, and how we're particularly responding on risk to harm. Neil, over to you from Calderdale.
Thank you. So just think, reflecting Calderdale, we are using the word harm quite a lot in all of our discussions. But probably when you look at the risk register, we're not flashing at 20s or 26s, but we are trying to take a system approach, and as you described, quantifying it to key indicators of that actual harm. So our elective care group and our urgent care group are discussing this because everyone recognises that there's a fear of it because we're in silvers and golds virtually constantly. So there is that risk and worry. But we're also trying to work with our chief nurses to quantify, well, how is that impacting on incidents and triangulating it. And so far we're not seeing that trend in, so fingers crossed, coming through. But we are, in assessing our risk and presenting it to our place base, ensuring as commissioners, as providers, we're aligned in the score of the risk so that we understand it and can articulate it rather than CCGs used to and ICBs now may have it as a 20, whereas a provider, it's the new norm sort of thing, and it's just how we are. So it is constantly up there. Patient safety and quality is key in everything that's done, and the word harm is used. But we're also trying to use the data to be able to support any actions that need to take place to rectify it.
Okay, thank you. Over to you, Carolyn Cook, please.
It's partly similar, not surprising, because some of our staff are shared, so you might expect some of that approach to be the same. I think some of this is about language and how it has evolved. So we had a conversation fairly recently in place about, do you keep putting in a risk that said organisations will be able to deliver care because of the amount of times they are at OPO 4, for example? There's that point when something switches from being a risk to being an issue that we are dealing with. And therefore the risk starts to change, that because of the issue we're having to deal with, that increases the risk of harm potentially. And there's just something about, I think Laura said this is a third risk cycle. I think with every one, it gets refined slightly and tightened up slightly. And I think when we see it coming through again, we might expect to see the language having moved on. But it's a similar approach to Neil's described, really, about triangulating that overall picture from the information we get. Just on a slightly different tack, something else that's a really high risk throughout here is going back to the question of children and young people and waiting times for mental health or neurodiversity assessments, for example. That we haven't just left it and putting it as a risk. So, in our quality subcommittee, we'll be doing a deep dive on those two issues over the next month or two. So we're bringing that through into the conversation that way. It's not like, say, just put a number in and then we forget about it. Absolutely not the case.
Okay, thank you. So a theme around patient safety, as well as an earlier discussion we had on finances and the relationship to that coming through in the oversight of a place committee and the reporting to ICB as well. Okay, Jo, then Tim, and then Brendan, then Sarah.
So I suppose the answer to your question, are we admiring the problem? I don't think we are admiring the problem. I think it links to what you say, Rob, about we've become more normal because this is the new normal. But I think if you look at Wakefield's risk, the issue why it's increased is because we're unable to meet our elective recovery. And that's because of the unplanned care that they're currently dealing with. And so we're off trajectory. So is there a risk? So we look at that in place and we're saying, actually, can we recover for the remainder of this year against that trajectory? And the likelihood is that probably not, because of the demands that we're facing. So I think this is quite a dynamic process that, as Mel said, can change from time to time. I think the fact that it does change should give you assurance that we're not admiring the problem and that we are. I agree with all my colleagues about the safety and harm is something that we talk about all the time. But in doing that, so the conversation we'll be having in Wakefield Places, so if that's a risk to us, what do we do to mitigate against the impact that waiting longer in Wakefield is having on our patients? And that's the conversation that I think now needs to happen or will be happening as a result of that increased risk.
Okay, thank you. Tim, over in Leeds.
Yeah, I think when you look through the risk register, some of the things from Leeds, we're flagging as quite a few as 20, and we're right on the edge, and that's where we are. That's how it feels regularly, that there is a real danger of what I'll call almost immediate harm now and harm today that clinical colleagues are having to manage. And, I would say nearly all our time and energy is focused on that, so it's not we're watching it, we're really concerned and continue to do that. Sometimes the actions you then take increase the likelihood of poor experience and a drop in general quality of care, but that is to mitigate real harm happening. So I don't think we've quite tipped into that real harm at a scale that's coming through and demonstrating it. But we are very mindful that we're on the edge of that, and that's why we're flagging it continuously and focused on it continuously within Leeds. The other thing, I suppose, around harm is the immediate harm, and that's what we tend to talk about. But I do think the waiting list issue and the knock-on consequences, but more than that, link back to the excess deaths conversation we had earlier, is that because all the attention is on the immediate pressure, there is a danger of longer-term harm. And we may be seeing that in things like the excess deaths data. So I don't want us to be so focused on that immediate harm of today that we lose sight of real longer-term harm that is coming to people as a result of that focus.
Okay, thank you. And the Leeds Summit that we had before Christmas, I think, was a good example of how Leeds are working on this together. They're working in a strong partnership, but then came to the ICB, and we've had support from NHS England as well. Is that a good practice in coming together across sectors and putting an action plan together? We just come to our sector colleagues. Brendan, Sarah and Karen, you want to come in as well. So Brendan, from the acute sector perspective.
I'd echo what colleagues have said, but I'm probably going to answer this with a question. What is the purpose of this board looking at a risk report that highlights the risks that numerous teams are looking over, that are completing trend analysis, acting upon? What is it we want this information to tell us? Is it to influence the national agenda, or is it to influence direct actions? I'm stuck with, I don't think anybody's admiring the problem. But my question is, well, what is the purpose of this risk register for this board? And I'm not dodging a question, but it's, well, why are we doing this?
Okay, thank you. That's really helpful, Brendan, in challenging back as well, because there is so much going on at place level and across sectors. Do you want to come back on that, Rob?
Yeah, I think this board's accountable for the safety of the citizens in the system and the staff that support them. And I think if we had doubts about the EPRR arrangements that we'd set up, if we had doubts about the way that we operate the SCC and things like that, Brendan, I think, you know, they would come out in this conversation. We'd be able to say, well, actually, I don't know what's going on each day, or we don't meet, we don't escalate, we don't do the stuff we had to do on oxygen or mortuaries over the period. But I think because we have that, we can be assured that we're doing all of the right stuff. But if there are things outside of our control, or if there are issues where we have to make decisions and choices which may lead to future harm, as Tim says, we then get into a conversation of what's the ethical framework within which we're operating to make those decisions and choices. And I would be saying to, you know, James and the clinical forum, can you dust off the ethical decision-making framework that you created for us in the pandemic to use, please? So I think that is a great question. It sort of exemplifies where we've got to add value here and where we continue to give permissions and freedoms to places and sectors to deliver on our behalf.
Okay, thank you very much. I'm conscious there are a lot of people who still want to comment, so if we take those comments and note them, and then we'll have a break before we finish up for the last part of it. So I've got inviting Sarah, Karen, and Tom to talk on behalf of sectors, and then I know AC, Jane and Rachel, and then Kim and Bev will still would like to come back to you as well. So let's see how we go. I'd invite you to be brief if that's possible. Sarah, over on mental health, learning disability and autism.
Yeah, I mean, I was going to finish with the same point that Brendan's raised. So within my organisation and within our sector, have risks increased over the last 12 months? Absolutely. They're articulated in our risk registers, in the reports that we give to our board, and all the mitigating actions that we're doing. And it's the same across BDCT and SWIFT as well. And they manifest differently because primarily the risk is driven from increased demand through the backlog and as a consequence of COVID and economic pressures, change in acuity and fundamentally workforce availability drives the biggest risk to delivering safe and effective services. And then there are two ways then where we go beyond the organisation in terms of managing those risks, because obviously I've got a statutory responsibility as a chief exec to keep services safe. That has never changed and never will. Within the Leeds place, you'll see referenced the stuff around continuity of care for complex mental health patients and where we need to make changes in terms of where we move workforce around which will impact on other services, so that's managing at a place. And then similarly, we do that with our partners, with Bradford and Swift, of where we're having to make decisions. So if I give you an example then, knowing in order to keep services safe and sustainable now, again, you'll see in the other performance reports, we've intentionally slowed down the growth in perinatal mental health because there's no available workforce in order to staff that growth. So it's making sure that we are not increasing risk in one service in order to pursue the growth in another service. And we're doing exactly the same in terms of complex rehab, slowing down the rate in which we repatriate and build place-based services because there isn't the workforce. And now exploring alternatives with the VCS and different methods of delivering services, which means that it's more sustainable on the long term. So it comes back to, I don't know what the value is in discussing those risks here. I think the very specific ICB operational risks that the ICB is responsible in its constitution to deliver, continuity, the impact of the strikes on the ICB staff, running of the ICB. But I suppose we've got the strategic risks for the ICB, and that's taking assurance that I've got in LYPFT robust arrangements in place. In our provider collaborative, we've got robust arrangements in place. In Leeds, we've got robust arrangements in place. So it gets into the territory of the ICB if there's a failure in any of those arrangements, which I suppose in the first instance would go via the quality committee for a patient safety issue, and we've had those conversations, haven't we, Bev? And in terms of assurance on controls would be via the audit committee. Is there any concern that we've not got appropriate EPRR arrangements in place? Otherwise, we'll tie ourselves up in knots trying to manage risk that isn't the role of the board to manage.
Thank you. Pragmatic and realistic as always, Sarah. Thank you. Karen, then Tom.
Thank you. So from a community services point of view, it's really important that we look at these risks as systems and as overall places, because as we shift the dynamic to recover the pressure in one place, Opal 4 to Opal 3, there's a real risk that if we don't understand what we're doing there, we just shift the lump in the carpet to somewhere else. And we have more people, for example, in community who are more dependent, who need more rehab and need more support. So it's really important that we continue to look at it as a system, and that's one of the places where I could see as an ICB, we could see, well, actually, are we just shifting the pressure around, and are we considering how we apply our resources to support that pressure in a way that is sustainable and safe? So I think there is somehow we can use this, not admire the problem, but understand, we think we've moved that issue, it looks like it's popping up here. Are we clear about what we're doing collectively to support and resource that? Thank you.
Okay, which comes to moving beyond the data and having that analysis as well. Thank you. Okay, Tom.
Yeah, there's a very high degree of risk within the local authority system, obviously in adult social care, everybody's aware of that, but also perhaps one we haven't discussed as much in children's social care, where there are high levels of demand, big elements of complexity, and the cost of living crisis hitting families really, really hard. The demand pressures are also in the system around the sort of community side of what we do in terms of that side of things, and people getting increasingly, increasingly concerned about their ability to deal with their own challenges. So yeah, high degrees of risk, and same issues around workforce and the need for integrated collaborative working even higher than ever. I just wanted to come back to the Brendan's really good question, because I think the thing we, I guess, have got to recognise is that this is the lens through which the national system has chosen to judge us. So we have a collective responsibility on all those things that Rob mentioned. I also think we always need a healthy scepticism about what we can do at this level and where the real accountability sits, which is at the trust level, at the authority level. But it is a shared accountability, really, and one that we seek to make the most of in terms of this level. And I'd much rather have this place lens than the traditional national look at everything. So it could be worse, I think.
Okay, thank you. Yeah, we'll move on. Okay, thank you, Tom. Yeah. No, I'm loving it. Yeah. And pragmatic also, as always. Thank you. And I think just that place lens, Robert and I have been having this debate probably for nearly a year now, is where we put place reporting and the focus on places. So, even just the reports are slightly further up the agenda this time than they were last month. So it's trying to invite that lens through all the time as keeping an eye on the accountability. And Tom, you're absolutely right. That's the lens that's we're being assessed and reviewed at the moment, which is ICB, ICS level. Okay, so AC and Rachel, did you have some comments separately? Or AC, do you want to go? I invite you to be brief, if that's okay, so I'd like to encourage us to have a break. AC.
Thanks. Tom eloquently replied to that comment, absolutely. And I think just a slight context about, we had a discussion in the Finance Committee as well about this, in what comes up to this risk register from places. And I think just extending the principles of how we do it and bring issues that affecting each part of the system, then if it's sort of something that is replicated, can we bring it up with mitigating sort of actions for us to review collectively as shared accountability. But I think in case of the wording of the first risk there itself should reflect that there is potential harm. And I think that's everybody shared their view and work has been progressed. That's not reflected on this risk as it worded right now. So that's something that's what they're putting. The second bit was looking at all the risks. It will be useful to see, because I think you have shown through indicators the movement of those risks over a period of time on the full researcher as well. So one particular would be useful to follow. Next one was 2188 in terms of the devolution of primary health. So it's at 16 with anticipated timeline in April. So by the next meeting, it will be useful to see, is it moving north or south?
That's really helpful, and we have committed to having another session on that, which we to follow on from the session we had last time. Okay, Jane, I know you've got an update from Audit Committee, which we'll come to. Rachel, did you want to make a point?
Yes, and I will be very brief. I just wanted to say that accepting all the discussion we've had about the levels that you discussed here and the assurance role of the board, I did find the common risk section really, really helpful, because actually what thinking about what the ICB at West Yorkshire can do, looking at that, I thought gave a really strong picture in terms of how we might look at our programmes of work across the ICB at West Yorkshire level and how we use them to influence those commonalities. So actually, that felt to me very much in the spirit of the ICB looks at things that it can achieve, across the whole of the 5 places, accepting that those 5 places will be doing, as Karen articulated, looking at the impact on the system in terms of where the carpet bunches up if you do one thing. So I just wanted to say well done to the group for that bit, because I just thought that was really helpful in understanding at least those things that are very much a West Yorkshire ICB level.
Okay, great. And we could bring that to the fore more in future reporting. Okay. Jane, have you got a comment? But I know you want to update on the Audit Committee as well.
So yeah, I comment on the risk register now, and I'll do the Audit Committee under the AAA report, if that's okay. So obviously Audit Committee, does play a role in terms of our whole risk management processes and the assurance around that. So Brendan, your question was a really good challenge, I think, to us as a board in terms of how are we doing it? Are we adding value? What's happening where? So I guess from my perspective, let me rehearse kind of what I think we are trying to do and how we can do it and how we can further develop it. So I think this space, similar to board assurance, was always something that when we constituted as a board, we knew was going to be something that we would evolve and develop through this year. And I think we're still on that journey. And I thought that at the start of this conversation today, and definitely comments and contributions reinforce that. But I think there's a clear direction of travel that hopefully people will feel comfortable with as we roll that out. So obviously, the board does have responsibility. This board has responsibility across the ICB and the places, etc. So we can't sort of just leave it to the places. I think there's been great work from the team in starting to pulling this together, so we have sight of, and all the detail behind it is there. And I think it seems to be, the adjustments, the movement of things from place to corporate, etc., that are suggested in here all seem to be starting to make sense, getting the calibration consistent, etc. So I think there's lots of good stuff happening. I think there is something still about then what do we do with it, and the reporting, and what conversations do we want to take place where, and then how do we get assurance as a board or awareness and sight of those conversations so that we don't randomly set off hairs within a board here and it repeats what conversations taken place elsewhere. So I guess for me, I would expect, you know, some of the place conversations that people have referenced today, where there are particularly high risk areas, I am still slightly surprised more of that doesn't come through on the AAA reports under the alert sections, even though you may be managing it, but just to sort of flag it, etc. So there's still a little bit of a disconnect for me there. And I was looking back at the minutes of the last board meeting when I made a similar comment, and it still feels like that. You know, I looked at Leeds' AAA report when Tim was commenting about concerns about harm, not mentioned anywhere in there. So I think there's something about that we need to develop, because that will help minimise repetition of discussion here. I think obviously the review at Finance and Investment Performance and Quality Committee and how that gets played back into the board as well, where they've thoroughly looked at some of this stuff. I think that's important, and again is where the heavy lifting should be done. And then I also thought the common theme stuff that Rachel is really helpful, and I wonder if that's something that we need to think about bringing into the reporting here, so there isn't just a collation of and the numbers and the scores on the doors of risk ratings, but taking some of those themes through the year and having a bit more of a deep dive across the patch and saying, importantly, what are we doing about it? So, you know, by nature, we limited ourselves with volume, etc., sort of saying what the risks are, but we're not bringing forward the discussion or the mitigations. And I think that's something that we need to do in the reporting. But I think the common themes are doing it that way, rather than purely through individual risks, might be a way to do that. So I think there's an evolution and further development, and hopefully, if we do it in that way, we'll start to not feel as if there's duplication. But we're all cited in terms of where we are on the risks. I think that is important, and somehow we need to get that balance. So those would be my thoughts and reflections.
Thank you, Jane. So I think then for the March meeting, that this report takes the common risks and the common themes, first of all, to spark the discussion, and the other information sits as an appendix. Let's try that out. Brendan, do you want to come back?
Well, only so I'm not seen as overtly critical or too blunt. But my point is, I think that's it. How does the risk inform our strategy? Or how do we start to break the cycle in some of what we're seeing? My point is there are teams looking at the actions to mitigate risk. At this level, this should be influencing our practice and our direction and what we want to see happen nationally. That's my point.
I think you've got the 3 points for discussion for the March meeting there on that document. Thank you. Okay. I know we've only got 45 minutes left of this meeting, but I really want to give you a break because this has been a long day for us all. Bev, would you just briefly talk about maternity work, because that's sitting in the report, and Kim maybe briefly on voluntary and community services, and we'll bring it back as an action and a follow-up for the next meeting as well. Bev?
So really briefly, with reference to risk 2198, this is around CNST and the delivery of year 4. Year on year, CNST gets increasingly difficult. They've articulated some of the risks to the delivery of that within the report, but also the PMRT, so the perinatal mortality review tool. 2 of our organisations missed on the reporting for that. It's been done, so hopefully some of the risk will reduce, and the oversight is again via the LNMS. In terms of reference 2197, the board is aware of this. This is around the MLU closure, temporary closure, that they're still closed, and that's still due to workforce availability, vacancies for midwives, but also really high maternity leave. Thank you.
Okay, thank you. And Kim, on the sustainability of the voluntary sector.
It's really hard to be brief on this, Kathy. I was struck by the discussions around harm and distress, and I think, you know, was also what Karen said about what we measure, we pay attention to, and of course we know that with the size and diversity of our sector, we can't measure some of this, but the level of distress that's coming back in terms of the people that are tipping up at the organisations in the sector is quite extraordinary, and I take a weekly call from somebody who's incredibly distressed about having to lose their services when they know that
those people are so vulnerable and where they're going to go. Where they're going to go is to A&E or to primary care. In terms of the work that Harnessing the Power of Communities are doing, we've put out 7 recommendations to the places and had really positive response from people. They're pragmatic recommendations, recognising the financial pressures that are faced and that the system, is facing. I suppose what we'd urge people to do is think about them as bravely and not being risk averse as they possibly can, and to cascade those messages down to the commissioning and contracting teams, because of course we're very, very lucky in West Yorkshire to have that buy-in at a strategic level. I think we're ahead of the rest of the country in that case, but we need some of that bravery and willingness to be innovative and do something differently in this space to happen right now. Because otherwise, it really is, it really is an emergency. But also to make sure that those messages are cascaded down to the people who are making those day-to-day decisions about decommissioning, which is, a live challenge.
Okay. I wonder, Kim, if we give you an agenda item for the March meeting, those 7 action plans linked to the cost of living action plan, and I know Jonathan's colleagues in finance are looking at social value and how you bring that further into commissioning. So if we give you that for next time in working with places on letting us know about the progress, because your point is this needs to happen now. So that gives us sort of 6-8 weeks or so to progress. Okay, thank you. And that's a system risk. Right, I'm going to invite you all to take a 5-minute break, but literally up, cup of tea back, and that's okay. And then we got half an hour left together, but hopefully that gives you just a quick break. So we'll just pause the live stream now, and thanks to those who are watching and listening. Welcome back to the last part of our NHS West Yorkshire Integrated Care Board meeting here in Leeds today. We've just got our final items on the agenda, particularly looking at our winter update, much of which we've covered, I appreciate, in our risk register in place updates, COVID-19 inquiry update from Anthony, as well as looking at our continued work on refreshing our strategy and an item on financial scheme of delegation, and we're aiming to finish at 5:30 today. Jane, I wanted to invite you as Audit Chair just to give us an update on Audit Committee. We have had a look over a variety of AAA reports and heard from places, but I know that you wanted to share an update from Audit Committee.
Yeah, thanks, Cathy, and apologies we weren't able to get the AAA report out for the board in time for today's board meeting from the Audit Committee. So I just wanted to give a verbal update on 2 items that would have been noted under the alert category. So as part of the work of Audit Committee, we obviously look at the internal audit plan, which is the work of that plan is really critical in terms of the assurance we are required to provide at the year end as part of our reporting to NHS, and the discussions with the internal auditors around the plan for this year suggested that there are some challenges in terms of completing the plans that we're currently facing in terms of resources and support. So we just wanted to take this opportunity to ask and encourage senior management who are involved in working on those audits, if they can please ensure that they're able to prioritise the resource on a timely fashion, so that we are in good shape as we approach the year end for that reporting. And then the second item was the other part of work that we do with regards to internal audit is obviously do the follow-ups and see how people have implemented actions that they'd agreed to from previous internal audits. With the setup of the ICB, we took over the responsibility of previous audit actions from the CCGs, and we've been monitoring the sort of completion of those actions to the timescales that we're committed to. There have been many that have been completed from the under the oversight of the places now, but there are still a chunk that have not yet been implemented. People have previously asked for some extensions to deadlines. At the Audit Committee, we were concerned at the continued requests for extensions, and so we have suggested to Jonathan that we should no longer be taking extensions or approving any extensions for those actions. So again, colleagues, particularly in the places, if they can try and help manage through the delivery of those, that would be helpful in terms of getting in good shape for the year-end reporting. Thank you.
Thanks, Jane. When's the date of the next Audit Committee? I suppose that gives us colleagues a deadline to give an update to you.
February.
February.
Mid-February, I think.
Okay.
20th, something like that?
Yeah, so that's the second, sorry if I could point, the second point that Jane raised around outstanding internal audit actions, that's going as a paper to the ICB Executive Management Team meeting next Wednesday, just to progress that.
Okay, and then that'll come to audit committee, so that's encouragement of colleagues to provide progress. Okay, thank you, Jane, that's really helpful. The next item, item 17, is our winter update. I'm going to take it as read because I think we had quite an in-depth discussion about work going on in places, how places and sectors are looking at current service pressures and demand, and also any potential harm and the mitigations in place. Does anyone have any questions in relation to the winter update in item 17? Anything for clarification or further assurance? No? Richard?
It's just almost as a forewarner for next winter's update. Many practices and pharmacies have got a surplus of vaccine because patients aren't coming forward for flu vaccine for a whole variety of reasons. And I know James and others across the ICB are encouraging uptake, and we're doing media work around that. But it's really challenging to do this. My fear is that practices and pharmacies won't buy as much vaccine next year based on this year's uptake, and so we could have a problem next year if we're not careful. So I think there is a lot more work still to be done to encourage people to come forward, because practices and pharmacies want to vaccinate people, are trying to vaccinate people, but it's proving really, really difficult at the moment. And that's obviously a challenge at the moment in terms of flu around at the moment.
Okay, thank you, Richard. James, do you want to respond?
Yeah, no, thanks, Richard. So as you said, there's an awful lot of work going to make sure that people do come forward still for both vaccines. And I think in terms of the plans for next year, absolutely, we will be taking that into consideration in terms of how we help with that, to give that confidence, but also understand in terms of the approach. And we are hoping over the next few weeks, month, that we understand a bit more about what that future plan is. Obviously, we're waiting for JCVI guidance in terms of what that is, but I know it's bigger than just that in terms of the flu vaccine as well as the COVID vaccine. So.
Okay, and we note the public campaign that's going on at the moment. Our colleague Karen Coleman in Communications and Marketing is with us today as well as part of that. And Anthony, at our last meeting you committed, and it's looking ahead, Richard, to review our winter resilience planning and its delivery in July this year, to then look ahead. So I think that's something to bring into that. But there is a here and now today, isn't there? And we're all advocates and leaders across health and care and encouraging colleagues and local residents to come forward for their vaccine. Robert's had to go to a NHS England meeting, but I think he'd talk about increasing people's confidence. I'm sure he talks to you all about this, increasing the public's confidence in vaccines as well. Okay. Anthony, is there anything else you want to add before we move on?
No, thank you. You covered it. Thank you very much.
Brilliant. Okay. Thank you for that continued report. And we'll have, this will be on the agenda for March and then back to July. So, I mean, it's always winter.
Yep, permanent winter. Yes. So we have a role in reviewing progress each meeting through the winter. So we'll bring that back as you say.
Okay, thank you very much. Okay, we'll move on now to our next item, Anthony, on the COVID-19 inquiry. We'll take the report as read, but are there any specific requests to the board or anything that you'd want to highlight in terms of the public inquiry that's moving into its third phase now?
It is primarily for information. So the report's been prepared for us by the NHS England regional lead for the COVID public inquiry, Sally Bell, and she's provided the same report for the other ICB boards in the region. So it's to advise the board that the inquiry is underway. It explains the national and regional arrangements that have been put in place to support providing evidence to the inquiry and learning lessons from its work. So it's for awareness and information. Happy to pick up any questions if colleagues do have any.
Okay. Any questions at all? No. I just wondered, Anthony, how we were recording lessons learned, having come from a provider trust within our system and then come into this role. I know previously we were continually recording the lessons learned. How are we recording that, archiving it?
Yeah. So I suppose first thing to say is that the inquiry, of course, is looking at the period before the Integrated Care Board became an organisation. So we don't have the history within the organisation as it is now of taking action through the pandemic. Of course, the predecessor organisations did, and there's been a process of recording all of the decisions made from CCGs and, of course, provider trusts as well. And all of the relevant records have been archived throughout the NHS for the relevant period. And the regional steering group that's been put in place is the place where that's all being brought together, if you like, and common lessons are being identified from that. So it'll be a process of action planning arising from that at a regional level.
Okay, thank you. And we recognise in winter, the previous winter 12 months ago, there were specific information and requests coming through from NHS England nationally and regionally on when we were in shadow form to undertake activities and play a coordination role. Now, for us as a system, we were already established in that way, and I know that you were recording the decision making and the ways in which we were coming together. So I just want to make sure that's in the minutes as well for us.
Thank you.
Great, thanks. Okay, last question was about extending the steering group to ICB board membership. Do you need a volunteer from this group, or do you think we've got good enough representation?
It's a management group rather than one requiring non-executive involvement. So Laura and I will represent the ICB on the group.
Great, okay, thank you. All right, we'll move on now to refreshing our West Yorkshire strategy. So this has been a continued story over many months. For those of you that were at the partnership meeting in early December, we had a full report there and some elements of this report. So Ian, you give us an overview, and Esther from our strategy team, welcome, and I know you're here to support Ian today.
Yeah, thanks very much, Kathy, and hi to Esther. Thanks for coming along. So what we want to talk about a little bit was the ICP strategy, how that then feeds into the joint forward plan for the ICB, the Integrated Care Board, and how that then feeds into and drives operational planning. So you'll remember that the strategy is owned by the Partnership Board rather than this board. The joint forward plan will be owned by this board, the ICB, as will the operational plan for 23-24. In terms of the strategy, we've shared with you a working draft of the strategy, and this was a document that we took to the Partnership Board last month. It's very deliberately a refresh of our 2019 strategy. The 10 big ambitions in there are pretty much the same as what they were previously, as is the vision around integration, tackling inequalities, stronger focus on prevention and collaboration. And that's deliberately so. We're trying to achieve a constancy of purpose, over the planning horizon. That document was fairly positively received, I'd say, by the Partnership Board in December. We received some helpful feedback around the importance of digital transformation as an enabler for change. Received some comments about it needs to be an ambitious document, but it needs to be tempered with reality given the current context that we're working in. And also there's some really helpful comments about the role of the Partnership Board going forward in terms of overseeing the delivery against those 10 big ambitions. So we're now refreshing and updating that document following that feedback. We're going back out to health and wellbeing boards. I think it was Calderdale last week, and I think it's Kirklees this week or next week. But we're really interested and keen to have comments from members of this board as well. The deadline for finalising that document is March. We'll take it to the March Partnership Board. So any comments, really grateful to hear now, or you can email myself or Esther. The Joint Forward Plan is a new requirement that was part of the Health and Social Care Act that was passed earlier this year. And this is a requirement that the ICB, this board, produces a 5-year plan which describes how the ICB will deliver its components of the health and care strategy. We've started meeting with the group that's been working with us on the strategy over the last year. We had a good conversation before Christmas. We think the Joint Forward Plan needs to do 4 things. Firstly, it needs to deliver the strategy and the local health and wellbeing strategies. Secondly, it needs to describe how we're going to recover performance against key national NHS targets. Thirdly, it needs to describe the delivery of the long-term plan, and I think this is where we'll get into a conversation about what do we prioritise over what time frame. And then finally, we need to talk about the transformation work that we're doing to support all of the above, and the way that we'll deliver efficiency through that transformation work. Guidance came out on the Joint Forward Plan on the 23rd of December. We've shared that with you as part of the pack. The headline, as it says, very little. It doesn't say much more than the Act does in terms of the development of the Joint Forward Plan. So our approach to this is we'll use the strategy design group, as I've said, and that group is continuing to work really well to work through how we develop this together. We will build it from places, we will work with provider collaboratives, and we will it will be supported by the West Yorkshire ICB programmes. We're looking to have a draft of that document by the end of March, and we're looking to do most of the work actually by the end of March to fit with the planning round, and a final document by, I think it's June the 13th, is that right, Esther? In terms of the operational planning, we've discussed that a little bit in Rob's update. Again, it came out on the 23rd of December with technical guidance, I think, coming out last Friday, which we're just in the process of working through and digesting. This is very much a kind of a numeric, one-year focus plan around activity, finance, workforce, how that all hangs together to support delivery of the strategic ambitions. We're doing it as a joint endeavour with Anthony's team, who will be leading the planning work, so that it's absolutely connected to the strategy and the joint forward plan. As Rob said, it's shorter in terms of the asks compared to previous years, but there's quite a lot in there still if you think about it in terms of recovery, long-term plan delivery and transformation. That is a significant amount of work, but we're using the same approach in the same group to ensure that that's all held together. The other thing that we're trying to do is we're working really closely with Kate's team and Joe Farn and Kate's team, so we're building in a organisational development approach to this, recognising that it's a new way of working between the West Yorkshire team and places and provider collaboratives to try and get the right connections and the right sort of working arrangements between those component parts. So we just wanted to share that as a brief update. I think we'll get into this more in the March board meeting. Esther, I don't know if there's anything that you want to add or anything that I've missed.
I can work out how to start switched on. Sorry. Thanks, Ian. I suppose just a couple of things to add. Firstly, in terms of the timeline, you'll notice the guidance says 30th of June. The reason we're aiming for the 30th of March is primarily because of the link to operational planning and how we're wanting to do that, but also the 30th of June doesn't really tie into local authority democratic timelines in order for us to be able to work with health and wellbeing boards. So we've been doing that for the last few months and we'll continue now over the next few months to make sure we do that well. The other thing just to say is that there is the statutory requirement for us to consult on the joint forward plan in a way that we didn't have to with a strategy. So Karen and her brilliant team have been working really well with us, so you'll have seen that consultation information go out. Please do share that far and wide. We're really encouraging people to do that so that we can get as many comments as possible in there. The other bit on the consultation side of things is, if you notice in the guidance, it does say that any changes we make, because we have to do an annual process around the joint forward plan now, an annual review, we have to go back to consult with health and wellbeing boards and the public as well on these things. So we just need to make sure that this is done really well this year so that we are in a slick routine in terms of business planning around that. The improvement side of things, as Ian alluded to, working with Kate and Joe and the team, is just, that really does build on the work we've done with the strategy design group, trying to build that system leadership. We're already starting to see improvement tools being used from that team out into places and providers, which has been fantastic. I think that's probably all to say, except that we do have a comprehensive slide deck that we've been sharing out with people across the partnership, and we can share that more widely if anyone would like it.
Okay, thank you. We've only got a few minutes left in the meeting. I don't know if there's any initial responses, comments or things to invite Esther and Ian to think through. And then Ian, you're saying you really welcome comments from board members, and maybe we could send an email out afterwards with a deadline for responses. Is there anyone who wants to comment immediately? For some of you, we've been watching this. I remember when we were all together in the art house in Wakefield, this is when we began that, and Esther, you joined us that day as well. So thank you for keeping us informed, because this is a vital document that we believe in and should be live and a working document for us all. Are there any? Jane?
Yeah, thanks. And it is a great document. I guess being new to the board, etc., it'd be helpful, I don't know if it's possible, to kind of reflect somewhere in terms of how it has been tweaked, amended, adjusted, either for the feedback from the people of West Yorkshire or for the environment in which we're operating. Obviously we want to try and keep true to what our strategy ambition was, but it would seem strange with the amount of change and pressure in the system that there isn't some sort of adaptation. And it would be helpful for me to sort of think about where we have and where we haven't, and for what reasons, in terms of taking it through for approval. Thanks.
Okay, thank you. Any other comments? No? Okay, silence is a good thing, Esther, after all your work of many months. I think what I wanted to reflect that the Joint Forward Plan principles from NHS England talk about making sure that it's fully in line with the wider system partnership ambitions, it supports subsidiarity, and its delivery is focused on specific objectives and milestones, which just sounds like our way of working. So these are good things, that this really supports our existing way of working as well. So.
Yeah, and apologies if I can come back in,
course.
Chair. I mean, I guess just reflecting back on the conversation around prioritisation, inequalities, transformation, prevention, I think this joint forward plan is going to have to do quite a lot of the heavy lifting around that in terms of describing the story, and I hope that it will, as we discussed previously, provide some of the mitigations and actions in relation to the BAF risks. The other thing, I think, the way we sort of describing the sort of the joint forward plan, so delivery of the strategy, recovery of performance, long-term plan, delivery and transformation, that might be the shape of the performance dashboard in future. And connecting the two things together, as Rob described, might be a neat way to do it.
Okay, and that fits in with an earlier agreement to develop the integrated performance report as well. Let's make sure it all works together in simplification. One of our missions from the December board development session was to reduce duplication and reduce the number of meetings we're all sitting in as well. So let's continue to work on that. Okay. Thank you for the update. That's really helpful. And I think there's a request there particularly to promote the opportunity to feedback and be involved in the strategy. So I think we'll take that as an action to send out afterwards. And I think also all the number of campaigns we're promoting at the moment for us all to share with our networks. Okay. One last point, Ian, was around investment in business intelligence. And this has been a theme throughout our day about making sure that we've got access to the right data or even recording the right data across health and care. Kate, you raised it earlier on workforce. What do we need to do, or is that something you're going to come back to us on?
I think we can come back on that. I think there's two elements of it. I think there's capacity, and I think we are light across the system actually in terms of business intelligence capacity. And I think there's something about ways of working. I think the BI leads are working quite well together, but I think it's clear that we're still duplicating work because of different approaches and places, and I think there's an opportunity to sort of streamline there, but the BI leads are, as I say, working together pretty well on that, and we can bring something back on that if that's helpful.
Okay, great. Okay. Thank you very much for your continuing work, because this is months and months of work. We've done you've worked really hard to make sure that people are included at the beginning many months ago and included again now, which is really appreciated. Okay. And thanks, Esther, for your work on it as well. Thanks. Okay, our last item, Jonathan, is over to you on delegated authority. So I understand this needs a board decision for approval.
It does. So I won't labour this paper, given the timing. So it's a paper that sets out a number of changes to the financial scheme of delegation. It reflects how the scheme of delegation has operated in practice since July through to October, November time. The paper was reviewed, considered and recommended for approval by the board by the audit committee in December. I'm happy to take any questions.
So are there any comments or questions, or as a board are you happy to approve this and the amendments? Yeah. Jane, yes? Yes. The audit chair says yes, that's good. Okay, all right, we'll take that as an approval. Okay, thank you very much. Does anyone have any other business at all? No? No? Okay. It's been a long day, colleagues, and I'm really grateful to you for your time and contributions and brain power and expertise that you've shared today. Thank you again to Kate and colleagues on giving us that focus on workforce. Thank you, Anthony, for giving us the picture and the overview in terms of our performance. And thanks to our sector leads and place leads for sharing a variety of information, and to our exec team as well for sharing their insights and giving assurance as well. As you know, this being our third meeting in public, we are testing format, so for anyone watching, you may see a slight difference from last time, and you'll see a slight difference as we go into next time as well. But thank you very much for everything. Thanks to our governance team, and thanks to anyone who has watched live or is watching this back on record as well. And we appreciate your interest in our work. And that's the end of our meeting. Thank you.